learned audience. Now the session for imaging. I believe the imaging is the very pertinent for the physician. I several times recall that sentence quoted by Dr. Jagat Nerula, who is the JAC editor. He said that if you are not an imager, you are not a physician. I believe this. So this session will be very exciting. I am requesting to get the chair, Professor Abdul Shafi Majumdar, Professor Sanjiv Mishra, Professor H.I. Lutfur Rahman, Professor Chowdhury Meshkat Ahmed, Professor A.Q.M. Reza, Professor Muhammad Khaliqujaman, Professor Mamnun Rashid Caesar, Dr. Muhammad Julfikar Ali, Dr. Muhammadullah Firoz, and Dr. Nusrat Ghaffur. Please take a chair. It's a great pleasure and honor to introduce Dr. Sanjiv Sharma. He is the president. He was president several times in different institutions, and he was awarded so many times by gold medal, and he was a lifetime achievement award, distinguished fellowship of different societies, visiting professors of different countries, chairman of Research and Education Foundation, national coordinator of Indian National and Registry, an honorary member of Indian Society of Vascular Surgery, and now he is the Pro-Chancellor of NIMS University of Jaipur, Chairman Institute of Imaging Science and Interventional Radiology, NIMS, and former professor and head of the Department of Cardiovascular Imaging and Endovascular Institute, AIIMS, Delhi. Now I am requesting Dr. Professor Sharma to deliver his speech. Thank you.
Thank you so much for your kind introduction. Chairpersons, dignitaries on the dais, friends, colleagues, ladies and gentlemen, I would greatly appreciate if all of you would sit down and settle down so that I can start my lecture today. Thank you so much for this kind invitation. I am grateful to Dr. Mohsin and his team for inviting me over to Bangladesh. This is the first time ever for me to Bangladesh, and I must say it has been a revelation and a very pleasant experience. I am overwhelmed by the warm hospitality and excellent care that Mohsin and his team have extended to us. Thank you so much. So friends, today what I'm going to do is to take you through a journey on how imaging is changing the way we assess cardiovascular risk for risk assessment for atherosclerotic disease, and more importantly, not assessing the risk, but making it more accurate and predictable. So as the previous speakers have emphasized repeatedly, the changing face of cardiovascular disease and risk assessment that is happening in South Asia in general, and specifically in Bangladesh, I was surprised to know that 20 to 40 to 45% of population is at risk for one or the other atherosclerotic disease. That's a very high prevalence rate. We do know that this is emerging as the most common cause of morbidity and mortality in our vulnerable populations. Over the last 2 decades, as I was talking to some of the members here a short while ago, imaging is changing the way we manage these patients. And why is this happening? Because we are able to recognize the disease early. We are able to characterize the disease, stratify the prognosis, and successfully identify the way to treat and to treat. These developments in imaging are rapidly changing the way we manage patients with cardiovascular disease today. But more importantly, today we also know that there is this emergence of rather effective, affordable preventive strategies that are evolving for reducing the cardiovascular risk in general. As an example, the lipid lowering therapy that we use. So therefore, risk assessment assumes a very prominent role in the course of preventive care for all adults. Traditionally, as Sandeep mentioned a short while ago, we had this Framingham Heart Score, we have this Inter-Heart Score, and we have a variety of scores which are used using various factors to assess the risk of developing cardiovascular disease. Imaging for cardiovascular disease risk assessment presents a paradigm shift in the way we assess and predict the accuracy of this disease, and that's pretty much what I am going to try and assess for you in the next 20-25 minutes or so. So why is assessing the risk important? Because it gives us an informed patient-centered management recommendation. So there is no generalization. We can be patient-specific in identifying an individual risk and use appropriate strategies to reduce this risk. There are many ways we can do this. We can use imaging studies targeted at various organ systems of the body, each of which contributes to an overall assessment of cardiovascular risk. Today, I am going to restrict myself to the cardiovascular system and show you what are the various ways we can use imaging to assess cardiovascular risk. So, there are two important aspects to it. One is the assessment of plaque. So plaque, as we know, atheromatous plaque, is at the root of causing various forms of disease across the body systems, whether it is the brain or the heart or the kidneys or the extremities or whatever. The second important area is the calcium. This calcium is very notorious. Why? Because wherever in the vessel it gets, it creates problem. You saw a very wonderful picture of an Egyptian mummy a short while ago, where a 4,000-year-old mummy also had atheromatous calcific plaques in the aorta and the extremity arteries. So assessment of calcification is directly related to the presence of atherosclerosis in the body. So these are the two fundamentals of assessing cardiovascular risk. And then there are some other aspects to it. The left ventricular mass and left ventricular geometry also predicts the occurrence of cardiovascular events. And then there are markers of endothelial dysfunction. If time permits, I will touch upon them very briefly. So let's talk about the most important aspect of assessing cardiovascular risk, and that is the assessment of the atheromatous plaque. Is it there or not there? Where is it located? How much of the vessel is it involving? And most importantly, what does it contain? This identifies plaque as a stable plaque or a vulnerable plaque. Vulnerable meaning the one which is likely to cause problems. As you know, the obstructive disease is only a small minority of patients. We do know that majority of fatal cardiovascular events develop because of non-obstructive plaques. So therefore, our ability to identify these plaques and categorize them as vulnerable is the key to assessment of cardiovascular risk. And how do we do that? So there are some very clearly defined markers of vulnerability on imaging, and we can categorize these plaques as stable plaques or unstable plaques. So this is actually a kind of a paradox. Positive remodeling of a plaque is dangerous, is bad, because this makes the plaque unstable and at risk for rupture and produce myocardial infarction. What does it mean? So in a vessel, when the plaque is present, if the vessel expands, it's bad. If the vessel contracts and produces stenosis, it's not so bad. Why? Because this may result in chronic stable angina, but it does not make the patient at risk for acute coronary syndrome. So there are many ways we use these imaging parameters to identify and differentiate vulnerable from stable plaques. There are many radiological signs which are described. I'm not going to bore you with it. The idea of showing you this slide is to tell you that today imaging can identify the plaque, it can quantitate the plaque, and it can differentiate between the ones, those who will remain stable, and the ones which are at risk for rupture. So we can target our preventive therapies to those who are at risk for rupture. And how do we do that? By starting statin therapy. We can characterize these plaques by measuring the plaque volume. We can characterize these plaques by assessing what is called as plaque stress. So these plaques are at risk for rupture. How does rupture happen? So we have these computational fluid dynamic models which assess the axial as well as the longitudinal stress and identify vulnerable points where this rupture will happen. And if we can do that, we can target our interventional therapies to reinforce these areas at risk and prevent a rupture and prevent an acute myocardial infarction. These are not fantasies, I can tell you, this is reality. And today, so let's say, in a given imaging technique, we are able to identify a plaque, characterize it as vulnerable, and identify a potential site for rupture. We don't have to wait for this stenosis to become 70% or 80% prior to stenting. These can be electively stented irrespective of the severity of stenosis, and a major cardiac event can be prevented. This is how the preventive cardiology imaging is progressing today. So there is a classic example here. Here is a patient who has an unexplained chest pain and who has a plaque. Now this plaque is at risk for an acute coronary syndrome if it has these features. And this plaque has a 0% risk of acute coronary syndrome if it has the following features. What does it tell you? It tells you that one, imaging helps to stratify patients, and imaging can also help identify necrotic core, whereby identifying this plaque as vulnerable and treatable for preventing major cardiovascular event. Now moving on, there is another very popular imaging technique that is used for assessing cardiovascular risk, and that is the measurement of carotid intimomedial thickness, what is called as CIMT. This is a simple procedure. You can put the transducer over the neck and examine the cervical carotid artery and measure the thickness of the wall of the cervical carotid artery. This is treated as a surrogate marker for atherosclerosis, and in patients in whom the thickness is increased, they are at higher risk for developing cerebrovascular or cardiovascular events. Now these plaques can be identified and they can be characterized too. By identifying the lipid core, we know the plaques which contain lipid, they are vulnerable and at risk for rupture. So there are now many softwares which are available which can quantitate these plaques, plaque volumes, as well as identify the lipid core in it, which makes these plaques as vulnerable plaques. Now, one more examination which is coming up in a big way, this is a very recent paper, and this is the use of MRI of the brain to assess the cardiovascular risk scoring. This was a very large study which was published a short while ago, and in all these patients, the Interheart and the Framingham Heart score were actually calculated, and then it was they tried to relate various MR brain parameters to these scores, and what they found was that simple cardiovascular risk scores are significantly associated with the presence of a subclinical cerebrovascular disease, which included the plaque volume, intraplaque hemorrhage, and silent infarcts in the brain. So if we can identify by imaging a hemorrhage within a plaque, this is a big achievement. Why? Because this identifies the plaque as vulnerable, at risk for a cerebrovascular event or a cardiovascular event. Does it mean that we subject all patients who are there for assessment of cardiovascular risk to brain MR? That's a big point now, because this paper has excited this discussion whether it is worthwhile using a big investigation, costly investigation to assess the risk for heart disease. Now, so we move from plaque imaging to the CIMT to the brain imaging. Now let's come to the crux of the matter, the most important marker for assessment of cardiovascular risk, and that is the presence of calcium in the coronary artery. This is popularly called as CAC. I shall greatly appreciate if you can stop this intertalk, please. And if those you don't want to listen, you are welcome to walk out, but please don't disturb my concentration. I'm sorry for being a little too blunt. So So calcification in the coronary arteries is the most important marker of coronary atherosclerosis, and this can be very easily detected in a simple CT examination without contrast today. So why is it important? Because calcium in the coronary arteries is 100% specific for atheromatous coronary plaque. That's lesson number 1. And the second important thing is a 0 score of calcium virtually excludes obstructive coronary heart disease. So 2 important take-home points which emerged from this large registry which was published way back in 2006 using first generation equipments. And this information holds true even today. So what does it mean? Does it mean that if you have a 0 score or a low calcium score, the patient does not have any significant heart disease? Let's examine this question a little more closely. So there are these 2 papers which were published, again, not too far away, but relatively far away. And what they showed was that these were patients with 0 calcium score, a large number of patients with 0 calcium score. And what was found that even though only a small percentage of these patients had significant stenosis, the problem was many of these patients had proximal non-obstructive plaques in the proximal LAD. Now we don't want to trifle with proximal LAD, we know, because this can be potentially life-threatening. So this cast a shadow on this concept of using coronary artery calcium as screening technique to exclude coronary artery disease. So what did it say was that in patients with a calcium score of 0, the frequency of non-calcific plaques was too high to be ignored. A similar paper, actually complementing this in a different way, was published around the same time, and what it showed was, again, a large number of patients with 0 calcium score were examined, and what they found was obstructive plaques were almost non-existent in the presence of 0 calcium score. So where does it lead us? Can calcium score predict an adverse cardiac event? There was this famous MESA study, all of you would know about it because MESA study is perhaps the largest quoted study in the field of cardiology, and they looked at this specific question of how calcium score will impact cardiac events. And you can see here, this is the line with 0 calcium score, and this is the line with a calcium score which is very low, 1 to 10. And they found a huge difference in all cardiac events. So a 0 calcium score virtually makes the occurrence of a cardiac event almost nil. However, when they extended to the same concept to fatalities from cardiac events, they found still a large difference between those who had no calcium to those who had a very small amount of calcium. So what did we learn? Clearly, absence of calcium is very reassuring. It tells you you are very, very unlikely to have obstructive coronary heart disease, and you are very unlikely to die of a major cardiac event in the foreseeable future. So the role of coronary artery calcium 0 and other risk markers for cardiovascular disease, this again was re-examined in a part of this or subset of patients in the MESA study, and they used a variety of risk factors. You can see here so many risk factors were examined. What they found was the coronary artery calcium perhaps was the best negative risk factor, and very closely followed by the CIMT. So calcium score of 0 and to some extent a thickened coronary carotid artery on CIMT, when they're used together, they are a very strong predictor of a negative risk for cardiovascular event. Framingham heart study, which is now actually, it's an ongoing study, as Sanjiv said, mentioned a short while ago. In 2017, it specifically looked at this issue, a large number of patients with 0 calcium score or more than 0 calcium score and no history of coronary heart disease. They were followed up for over 7 years, and this is what it showed. So whether it is the presence or absence of, let me show you in a better way, you will understand this better. So patients who had 1 to 100 calcium score, patients who had 101 to 300 calcium score, and patients who had more than 300 calcium score. Now see, what happens? Patients who have a 1 to 2 segment of the artery involved versus patients who had multiple segments of arteries involved, patients who had one coronary artery involved versus patients who had all coronary arteries involved. Presence or absence of calcification is quantitatively involved as predictor of outcome. So, those who have high calcium, those who have more segments of the coronary artery which are involved by calcium, those who have more coronary arteries which are involved by calcium, and those who have more proximal coronary arteries which are involved by calcium have a cardiac event. So what do we learn from this? We learn that calcium score is almost semi-quantitatively associated with the risk of obstructive coronary heart disease and as a surrogate marker of mortality or morbidity from cardiovascular diseases. That's a very important take-home message. Now, 10-year survival in patients who did not have any calcium is 99.4%. So it tells you that today you get a screening done to see calcium in the coronary arteries, and if there is no calcium in the coronary arteries, your likelihood of developing a major cardiovascular event is less than 1%. That's what it tells you. I'll skip this for the purpose of time. So how do we summarize all this that I discussed today? So use of calcium score to screen patients with intermediate risk based on the Framingham score is the way to go. That's number one lesson. Absence of calcium virtually excludes obstructive coronary artery disease, lesson number 2. A positive calcium score indicates an incremental risk, and I will show you how this relates in a short while. And it can alter the therapeutic goal for treatment for LDL, for treatment for blood pressure, or whatever. Zero calcium score, for the next 8 years, you are reasonably secure. So the question that I'm asked repeatedly is, oh, look, I have no calcium today. Should I get this repeated after 1 year, after 6 months, after 2 years? The answer to that question lies here. A zero calcium score, there is no need for a repeat coronary calcium score scan for next 8 years. That's very important take-home message. Calcium score of 1 to 100, there is a 2% risk of developing a cardiac event at 2 years, and with every next successive block of this calcium score, this risk almost doubles. Those who have a over 1000 calcium score are at very high risk for developing a major obstructive coronary artery disease, and they should be treated appropriately. So we talked about plaque imaging, we talked about CIMT, we talked about coronary artery calcium. Are there any other ways of assessing cardiovascular risk? There's one more example, and that is the epicardial fat. So epicardial fat we commonly see in CTs. Can we relate this to cardiovascular disease? Yes, we can. Actually, this was one large study we did at AIIMS a short while ago, wherein we calculated the volume as well as the character attenuation coefficient of this fat, and we showed that there is a almost linear association with the amount and the type of fat which surrounds the heart and the risk of cardiovascular disease. So just imagine now a situation where the patient goes for a coronary artery calcium estimation, which is a simple CT procedure, outpatient procedure, not much radiation issue, no contrast needed. In the same examination, you can assess the calcium score, you can assess this epicardial fat, and both can be clubbed and appropriate information can be provided. Of course, this calcium score can be converted to CT coronary angiography as well, and I don't want to bore you with all these various issues of why and how we do coronary angiography. All I want you to know is that in appropriate patient populations, CT coronary angiography can be used to screen for for abnormal coronary artery disease. Which is this group? Let me say this again. I am not saying that CT coronary angiography should be used for screening for coronary artery, for atherosclerotic risk. It should never ever be used for screening for coronary artery disease. That's an absolute emphatic statement. However, in selected patients, like for example, athletes, you would see this every now and then in the news, a young athlete or young footballer plays on the field and dies suddenly of cardiac event. Why does this happen? This happens because of anomalous coronary arteries. For example, here, this is a reconstructed version of a CT coronary angiogram. This is the anterior side, this is the pulmonary artery, this is the posterior side, this is the aortic root. These are the three sinuses of the aorta, and normally from the left sinus, the left coronary artery arises, from the right sinus, the right coronary artery arises. In this case, the right coronary artery is arising from the left sinus and is trapped between the two great arteries, what is called as the malignant course of the right coronary artery. And these are the patients who are at risk for developing sudden cardiac death because in situations of extreme stress. Whenever the blood pressure goes up or there is a stress of for whatever cause, and this artery can get constricted and these patients can die. So these selected patients can be screened by CT coronary angiography. Is it good? So this is, again, I will show you only one slide for this very old study. What did it show? It showed a negative predictive value of over 99%. What does it mean? It means that a patient comes to the emergency room with an acute chest pain, has a plus minus or some ECG changes, the biomarkers are plus minus. You don't know, should I take this patient to the angio room or not? Do a CT angiogram, and CT angiogram is normal. You can rest assured this patient does not have significant obstructive coronary artery disease. That's what is important. The CT can also be used to assess the ventricular function. You remember in the first slide I showed you, the left ventricular mass and the geometry are also markers of cardiovascular disease, and we can use the CT to measure the ejection fraction. That's a small part, but we can use the CT to measure the left ventricular mass and look at the left ventricular geometry. So it's a one-stop shop all. It can provide information about almost anything and everything. So the question that I am asked frequently is that, look, if we are going to do this imaging, what is the risk of imaging? In other words, assessment of risk for cardiovascular disease cannot be done by a procedure which produces a risk in itself. So risk of imaging has been studied actually by, this was actually published on behalf of the European Society of Cardiology in the year 2020. And what it showed was that lifetime risk of an imaging procedure for fatal events is small, very small. Important thing is that you give aspirin to all patients for reduction of cardiovascular risk. Aspirin usage has more than 7-fold increase in the risk vis-a-vis cardiac imaging. So that puts in perspective the risk of imaging for assessment of cardiovascular risk. This risk is almost as much as a daily life activity like walking, swimming or bicycling. So this is the level of risk that imaging procedures have. So to conclude, my friends, what I would try to tell you is that cardiovascular risk prediction is a critical part of cardiovascular disease prevention. There are many strategies that can be used for assessment of this risk. Two things, coronary artery calcification and carotid plaque assessment by CMT are the way to go to assess this risk, whereas the coronary artery calcium predicts better the coronary artery events, the carotid plaques predict better the stroke events. Short-term risk assessment, actually when you combine imaging with biomarker assessment, you improve the accuracy of risk prediction. I thank you so much for your kind attention. If you have any questions, I will be happy to answer.
Thank you, Dr. Sanjiv Sharma, for your excellent and comprehensive presentation. Now, question answering session. I'm requesting from the audience, if you have any question, please raise your hand, or if you have a question, please.
Thank you very much, Doctor, for your elaborate discussion on calcium, coronary artery calcium, and the result of this, and the atherosclerotic plaque in the artery. I would like to know one thing, that if you like to do the coronary artery calcium detection, should we use the same dye as we use in the during normal coronary angiogram, or for only detection of the calcium in the coronary artery? The dye is same or not?
Well, you don't use any dye for coronary artery calcium score. It's a simple non-contrast CT, which patient can walk in. There is no need for injection of any contrast, and it can be done just straight away. It just takes 1 minute, and the patient can walk back home. Yep.
You have shown that some of the athletes dies because of the right coronary artery is originating from the left coronary sinus. But as a cardiologist, you know that sportsmen, when develop the athlete cells, by virtue of their hypertrophic cardiomyopathy and also a lot of arrhythmia, the sudden cardiac death occurs in the athletes. So, from your experience, what is the incidence of death, sudden cardiac death in the athletes because of this origin of the right coronary from the left coronary sinus?
See, so this problem is multifactorial. Malignant course of the coronary artery is one of the many causes of sudden cardiac death. It's not the only cause of sudden cardiac death. It could be hypertrophic cardiomyopathy, it could be IHSS, it could be malignant course of the coronary artery. This malignant course of the coronary artery is very uncommon, less than 1% of the coronary anomalies as a whole. So as such, it's very rare, but because of the increased use of cardiac imaging, we are seeing it more often. Like for example, I will tell you Al-Kappa. We used to think, oh, it's a problem of infancy or neonates. But I can tell you today, we see Al-Kappa in a 68-year-old man, 58-year-old man. I have seen one Al-Kappa in an 82-year-old lady. So we are seeing this far more commonly now than we were seeing because we were not imaging them. That's the problem.
Hello, sir. Hello. May I ask a question, sir?
Yes, please.
You know, in the coronary artery, calcium deposition occurs in two sides, superficial and deep. Superficial means it's towards the intima, and deep means towards the externa. My question is, how calcium goes towards the externa?
So this calcium begins actually in the intimomedial junction. So calcium which is localized to the intimomedial junction is what we call as spotty calcium. That's less than 3 millimeter in width. So this spotty calcium is a marker of vulnerable plaque. But when the calcium extends intramurally to go onto media, because see what happens is that these diseases begin in the subintimal space, but they gradually extend to involve a segment of the wall of the vessel, the media and going into adventitia and into the periadventitial planes. Most of this calcification is actually dystrophic. So dystrophic calcification develops after the inflammation has established itself. So to begin with, it is in the subintimal plane, and these spotty calciums are the markers of vulnerable plaque. If the calcium is circumferential, involving the mura, that is the wall of the blood vessel, that generally does not result in rupture, and we don't really worry too much about it.
Excuse me, I have a question to Dr. Sharma from the audience, from the point of view. Actually, who are the candidate for coronary artery calcium?
Okay,
which group?
Very good. Sure, I will tell you. Let me. Can we go back to this presentation, please? Sorry. Can we project the presentation again? In the interest of time, okay, I skipped that slide, but I will show it to you. Not an issue. And you forget it. So what I will just tell you. So who should be screened for coronary artery calcium? These are patients. So patients who are at low risk for coronary heart disease should not be screened for coronary artery calcium. This screening technique should be reserved for patients who are at intermediate risk for coronary heart disease, who are older than 40 years in age, or who are old beyond 65 years of age. Those who have had no cardiac event. So these are patients who are asymptomatic, and this is used as a investigation for assessment of risk in an asymptomatic patient population.
Okay. Thank you. Now I'm requesting Professor Shafi Majumdar sir to say something about. Do you have a question? Okay.
Good evening. I have a question. It might be the last of the question part. May I know how far the calcium consumption is related with calcification, coronary calcification? In one of your slides, you have presented that if the calcium score is 0, once investigated, for next 8 years, the cardiac coronary calcification or risk of that is almost nil. So how to relate consumption of calcium with coronary calcification?
Consumption meaning?
Calcium.
Consumption of calcium?
Calcium supplementation.
Oh,
Yes,
calcium supplementation.
Dietary consumption.
So dietary consumption. So this is again, this is a concept which is not so well investigated. Does increased intake of calcium relate to presence of calcium in the coronary arteries? Well, the answer to this is at this time is that no, there is no linear relationship between calcium intake and deposition of calcium in the coronary arteries, because this is largely a dystrophic calcification.
Thank you. Thank you very much.
Okay.
I have a comment on use of CT calcium in the group of patients who needs it. In addition to the patient who has got intermediate risk as per score risk stratification or Framingham risk stratification, there are certain groups of people, like people with erectile dysfunction in the young people. As we know, it came from Princeton 3 recommendation that the patient with erectile dysfunction in their young age do have are potential to develop the coronary artery disease. There are some certain subgroups, even if they have lower risk, and then again they can go for calcium scoring. My second concern was about the intimal medial thickening. As you know, the the measurement of intimal medial thickening had been recommended in American College of Cardiology as class 2 indication and before 2014. But thereafter, it has been relegated to class 3 recommendation. That is one question I do really have in my mind. And another point that I want to just share with you, Dr. Sanjiv, as you have mentioned that epicardial fat can be seen with CT scan, but we have a little study with our students, and we tried to look at the epicardial fat echocardiographically, and we also had looked for epicardial fat in the intraatrial septum, and we found that there were some correlation between this fat and the coronary severity. And my last comment is that again, this is from our students' research work.
Yeah, black backpack. Yeah. Yeah.
Okay.
Yeah. So you are right, actually. I did not, in fact, elaborate on that. So there is one example I will give you. Heart failure is a very big problem. Patients who have unexplained heart failure, calcium score is used to assess the presence or absence of atherosclerotic heart disease. So in patients with unexplained heart failure, coronary artery calcium assessment is used as a way to identify the cause of heart failure. So that's a very big group who undergoes their calcium score assessment today. So you're right, there are many subgroups which are quantitated. And unexplained chest pain in a young patient, that's another example where you would want to know, to exclude coronary heart disease, you would do a simple plain non-contrast coronary CT. CIMT actually has gone into, you are absolutely right. So what has happened is from 2002 to 2020, the level of certainty for acceptance of CIMT as a surrogate marker of atherosclerosis has gone down. The reason is actually primarily relates because this is a very subjective assessment, operator dependent. So today there are many softwares which are available which automatically quantitate and qualitate the presence and the content of the thickness of the carotid wall. So an appropriately done CIMT still is a useful technique, but it is not as useful as C is, that is coronary artery calcium is. So that was the epicardial fat can be used, is a surrogate marker, there is no doubt. How you detect it, whether by CT or by echocardiography, that's a different issue altogether. Echocardiography can also assess it, CT can also assess it, but the quantitation of the volume is better depicted on CT. That's the only thing I would want to add. And the fourth thing that you mentioned about the, what was it? I'm sorry, I forgot. Actually, I was preoccupied trying to locate my laptop bag. And that's why. Annular calcification. Yes, absolutely. This is a very big subject today. The assessment and quantitation of annular calcification on CT and relating it to atherosclerotic cardiovascular events. That's a reality, and more in the aortic valve than in the mitral valve. Mitral valve calcification actually is age related, is degenerative, and does not really correlate very well with the risk of atherosclerosis. But aortic annular calcification is, to the contrary, related to the overall atherosclerotic burden of the patient and is seen as a surrogate marker of atherosclerotic disease.
Okay, thank you. Sir, I am requesting Professor Sohi Mojumdar sir, please comment about the session.
Thank you, Professor Sharma, for the nicely depicting the usefulness of the calcium score and other things. Because I am interested more on the coronary artery calcium score for the for the assessment of the risk assessment for the prevention of the cardiovascular diseases. My simple question is, in this area of the globe where there is no scoring system developed, should we be more liberal to undertake the coronary artery calcium score for assessment of the risk of the atherosclerotic cardiovascular disease?
Well, what we teach, unfortunately, is not practiced. So today, it is perhaps the most abused investigation, that is a CT for assessment of calcium score. Everyone gets a CT for calcium score, and sadly, they keep repeating every year too.
It goes in favor of you.
No, I would not want this to happen. That's why on every forum, I repeatedly emphasize a low or a zero calcium score. Please, for God's sake, do not repeat it for 7 to 8 years at the very least. Patients who have a history of chest pain, patients who have some form of coronary artery disease diagnosis established, please do not do calcium score. Why? Because it's not that it cannot be done. It adds to the radiation burden. It gives just 1 to 2 millisieverts. That's almost like your annual radiation dose. But then this patient will repeatedly need other investigations. At some stage, he will need a coronary angiogram. Just to put in perspective, a calcium score assessment will give you a radiation exposure of about 1.5 millisieverts. A coronary angiogram, catheter angiogram, will give a radiation exposure of 12 to 20 millisieverts. So that's almost 20 times. But then this patient will not be satisfied with calcium score. He will undergo a coronary angiogram. So it adds to the radiation burden.
I was talking about for the primary prevention.
Primary prevention, yes.
Not for the
yes,
established disease.
I would be more liberal in South Asia.
Yeah, I was talking.
Yes,
like
I agree with you 100%. Yeah. We should not be so rigid in terms of identifying patients for calcium risk assessment. Why? Because there is such a huge prevalence of diabetes, dyslipidemia, smoking, pollution. So many factors are at play in our patient population. So therefore, we should use it more frequently than we do. I agree, 100%.
Thank you.
100%.
Sir, I'd like to add with this comment. Actually, calcium score risk acts as a risk enhancer. When we put a patient in a pool cohort equation, those are intermediate group. If we see the calcium score, then we can reclassify as high risk group to get high intensity statin as well as aspirin, or downgrade if the calcium score is 0, then you can de-risking the patient of intermediate risk group to reduce the statin or even don't continue the statin. So calcium score is an risk enhancer. They can modify the statin as well as prediction of the future risk. Thank you.
Let me just add a couple of things to this. See, what happens, so when there is a 0 calcium score, there should not be very abnormal elation also. It does not mean that you are not at risk for coronary heart disease. So there, it is not, does not mean that you go for partying and start, smoking away to glory or drinking away to glory or start all these bad lifestyle habits. That's what needs to be stopped. Negative 0 calcium score just tells you that you are not at risk, but you need to continue the lifestyle modification. That's one thing. Second big question which I have frequently asked is this issue of statins. So if there is a 0 score, well, you can downgrade the risk and you can perhaps stop statins. That's important. But if the patient is on statins, calcium score should not be used to stop therapy. What happens these days is, calcium score of 200 and the patient is on statin, and then he comes back to know, let me get another CT done to see whether my calcium score has reduced or not. Remember, statins do not alter. Once there is calcium, it won't go away. So therefore, do not repeat CTs to assess the efficacy of statin. CT for calcium score is not the way to assess the efficacy of statins. Second important thing is, statins increase the calcium initially. So a calcium score of 100, patient is on statin, that score will increase to 120, 130, 150. It does not mean that the statin is not working. Statins actually work by initially increasing the calcium score. Just remember this.
Actually, there is a misnomer here. By statin, calcium density is increased, but non-calcified plaque is reduced.
Yes.
We know Agustin score is the multiplication of plaque volume or area and calcium density. So if you use statin intensely, then plaque, non-calcified plaque become reduced, rather calcium density is increased. So it falsely, you can see that my calcium score is high. Is it working? I think this is the answer. So it is due to the time constraint. I'm requesting our only one cardiac radiologist. She's Dr. Nusrat. She's working in Ibrahim Cardiac Center.
Thank you.
Please say something about this.
Thank you. Time is very short. Everything is discussed very elaborately. কিন্তু আমি যেই কথাটা বলতে চাই আসলে আমাদের দেশে কার্ডিয়াক ইমেজিং এতটা প্র্যাকটিস হচ্ছে না, কার্ডিওলজিস্টরা এতটা বুঝতে পারছে না কিভাবে আসবে আসলে কার্ডিয়াক ইমেজিং, হাউ হেল্প দেম আউট ইন দেয়ার ডিফিকাল্ট কেস। ওনলি আমি দুইটা কথা বলবো, ক্যালসিয়াম স্কোরিংয়ের ক্ষেত্রে কার্ডিওলজিস্টরা কখন আমাদেরকে বলবে কখন বলবে না, এখানে দুইটা জিনিস পয়েন্ট আছে। একটা হচ্ছে ক্লিনিক্যাল রিস্ক স্ট্র্যাটিফিকেশনে যারা ইন্টারমিডিয়েট রিস্ক গ্রুপে আছে, sometimes someone get confused whether they start statin or not. In that case, calcium play important role. They can send patient, if there is a calcium, even 10, then statin can start. And another age, patient group, diabetic and under 40 years. They also need statin therapy. So when they come in checkup, they can, clinician can ask for calcium scoring, and it is easier to help them, clinician, they start statin or not. At this moment, আমাদের cardiologist, cardiac imaging এর যে combination, এটাই আমার মনে হয় main messageটা from my side to our cardiologist. Thank you very much.
I have a question, sir.
Yeah.
Sir,
Yes,
I have a
please.
question.
Yeah,
All
yeah.
of we know
Govindo,
the coronary artery disease.
Very good, short question.
Yeah? Yes,
Very
short
short
question,
very
of
short
course.
question. Yeah.
Coronary artery disease is a chronic inflammatory disease, atherosclerotic disease. So, calcium score is sufficient for prediction of development of atherosclerotic cardiovascular disease, that means acute coronary syndrome. Is there any other biomarker, inflammatory marker have role?
Yes,
Is
of course.
sufficient only, CAC
No.
score?
So calcium score identifies the risk of presence of atherosclerosis, and that's it. There is a semi-quantitative method to relate the amount of calcium to the severity of obstructive coronary artery disease. Beyond that, do not replace coronary angiography with calcium score assessment. They are two different things altogether. Number one. Number two, the biomarkers for presence of inflammation in the heart have their own place, and when biomarkers are combined with calcium score assessment, they improve the prediction of cardiovascular risk in a given patient.
And plaque composition, not only calcium, here are so many factors, so many components.
Exactly. So presence of calcium or absence of calcium in the plaque is not important. Presence of lipid core and necrotic lipid core is the key to identifying vulnerable plaque. So there we don't talk about calcium, we talk about lipid and lipid core and the ulceration, that is the absence of fibrotic cap on the plaque. That's what all this plaque imaging is all about. Unfortunately, I could not go into more detail because it will bore many people who are not interested in imaging. But there is a way to identify clearly which plaque is vulnerable, and the way to do that is by identifying the lipid content and quantifying the lipid content of the plaque.
Thank you, sir. I must have
I hope you can come again in Bangladesh because so much interesting. Sir, wait.
So I am requesting Professor Majumdar sir to give the memento to Dr. Sanjiv Sharma. Please come here.
Distinguished faculties, guests, and ladies and gentlemen, very good evening. Now the world is moving towards the prevention of cardiovascular disease. And this session is designed with the management for cardiovascular protection. The control of risk factor and lifestyle modification, we all know the cornerstone of prevention of cardiovascular disease. And we have a very renowned speaker in this session. And the chairperson of this session is Professor Nazrul Islam sir, Professor Hasina Banu, Professor Razia Sultana Mahmood, Professor Abu Azum, Professor Abdul Kader Akhundo, Professor Fazilatun Nessa Malik, Dr. Abdullah Al Jamil, Dr. Shahjada Selim, Dr. S.M. Kamrul Haq, and I'm Dr. Farhan Ahmed with you as a moderator. I'm requesting all the chairperson of this session to come on the stage and have their seat. Please. We have very renowned speaker in this session. We have Professor Subdeep Mishra, Professor Abdul Wadud Chowdhury sir, Professor Abdullah Al Shafi Majumdar sir, and Professor Indrajit Prasad. Please, all of our chairperson, please come on the stage and have your seat, please. May I request? Thank you. Now I am requesting Professor Subdeep Mishra, Vice Chancellor, NIMS University, Rajasthan, Jaipur, India, to deliver his talk on dietary and lifestyle management in cardiovascular protection. Sir, please. Professor Subdeep Mishra, sir.
So thank you again for having me here. And I have been tasked to talk about dietary and lifestyle management for cardiovascular disease protection. So what I think I will cover is, number one is I will talk about evidence regarding diet and cardiovascular disease in terms of dyslipidemia, hypertension, stroke, CAD, coronary artery disease, as well as in the outcomes. Then I will talk about other lifestyle interventions other than diet, which is weight reduction, exercise, cigarette smoking. Then I will little bit talk about the special problem that we have in South Asia, particularly about diet, about physical inactivity, and about obesity. And then finally, I will have a bit of discussion on what we can do in this situation. So we know that poor diet contributes to one of the 4 of the 6 leading causes of death now. So a diet can be linked to 4 out of 6 causes of death that we know, and it can lead to heart diseases, it can lead to cancer, it can lead to stroke, and it can lead to development of diabetes. The good part about diet is that it is a modifiable risk factor, which means that you can improve diet and that can help. More important is that if you can improve diet, you can decrease coronary artery disease. The question remains how to do it. So I will little bit talk about that. So coming to diet and dyslipidemia, I think we keep hearing this jargon, MUFA, PUFA, and trans fat, etc. And we keep wondering what it means. I think, simply what I wanted to tell you was that in any oil, if MUFA content is high, that leads to reduction of bad cholesterol, that is decreased LDL, and improvement in good cholesterol. So the MUFA is the best kind of oil that you can have, which leads to bad cholesterol decreasing and good cholesterol increasing. On the other hand, PUFA, that is polyunsaturated fat, leads to decrease in the bad cholesterol, that is LDL cholesterol, but unfortunately it also leads to decrease in good cholesterol and increase in triglyceride. So as you can see that partly PUFA is beneficial because it can decrease LDL, but if a lot of PUFA is taken, then ultimately it will also lead to reduction in HDL values. Coming to the saturated fatty acid, while it increases the bad cholesterol, LDL, but it also increases the good cholesterol. So this is what deshi ghee does. It increases bad cholesterol, but at the same time also increases the good cholesterol. But the worst kind is the trans fat, which increases the bad cholesterol and decreases the good cholesterol. So you can see that all these 4 have different kind of effects on the lipid profile. Now what about dietary cholesterol? So we keep hearing, keep seeing foods where it is written no cholesterol, 0 cholesterol, and then there are certain foods we know are high in cholesterol, for example egg, which we know because of the yellow part is very high in cholesterol. So what does it mean? In reality, it does not mean anything, because whatever cholesterol you take in diet actually gets broken up by the gut, and therefore any kind of cholesterol that you consume in diet will not get translated into blood cholesterol unless lot of it is taken. So if you take 2 eggs per day, it is okay. But if you take more than 2 eggs, then maybe some cholesterol may be added to the your blood. Otherwise, 2 eggs, no cholesterol will be added. Now coming to important thing is that the reality is that if you have a diversified diet, so which means you use different kind of oils, you use different kind of foods in your day-to-day meals, then that is something which is found to be very helpful, and so that is, I think, something to remember. As a matter of fact, not only diversified diet improves the dyslipidemia, it can have a very good effect on blood pressure as well. And this particular study, which was done in the DASH group, it showed that a diet enriched with fruits and vegetable, low in fat and cholesterol, led to a reduction in systolic blood pressure of about 5.5 and diastolic blood pressure of 3. So a diversified diet not only improves the lipid profile, but also reduces the blood pressure. Now coming to impact of diet on blood pressure, there are evidence that sodium restricted diet can reduce blood pressure. As a matter of fact, if you could reduce the dietary sodium to 80 millimole per day, then there could be a reduction of 5 millimeter systolic and 3 millimeter diastolic blood pressure. If you could bring it down to 65 millimole per day, then systolic blood pressure shows a progressive decrease in systolic blood pressure. So you can bring down systolic blood pressure by 7 if you go a marked reduction in the sodium levels. What about potassium? The InterSalt study showed that if you increase potassium consumption as measured by urinary potassium, you could actually lead to a decrease in systolic blood pressure by that term alone. About 2 to 3 millimeters of blood pressure can drop by increasing the intake of potassium in the diet. What about stroke? Very interesting study. It showed that if you increase the consumption of potassium, you can actually also decrease the risk of a stroke. Published in the prestigious British Medical Journal, and it showed that if you increase the consumption of potassium, the risk of a stroke can be decreased by simple increase in potassium consumption. Now coming to effect of diet on manifest coronary artery disease. Since till now we had looked at impact of diet on the risk factors of coronary artery disease. What about the real coronary artery disease? So what I will do is I will talk about these components of diet and then show how they impact on coronary artery disease. What I will talk about is fat and their subfractions. I will talk about carbohydrates. I will talk about fruits and vegetables. I would talk about whole grains and fiber. I will talk about fish, and then I will talk about certain diet regimens that you keep hearing, Atkins diet, keto diet, etc., and their impact on the coronary artery disease. Now the thing is, the percentage of calories that you derive from fat. So normally the percentage that is recommended is about 30% of calories should come from fat. But if more than 30% calories start coming from fat, then you can see there is a linear increase in the risk of coronary artery disease. So if most of the calories are coming from fat rather than from some other sources, then risk of coronary artery disease increases. What about these things, MUFA, PUFA, etc. we discussed. We know that MUFA increases the good cholesterol and decreases the bad cholesterol. And as a matter of fact, in Mediterranean countries, it has been shown that maybe one of the reasons for pre-med or a Mediterranean diet is because the diet is high in MUFA content, among some other things also, which we can discuss later. So what are the rich sources of MUFA? Olive oil, mustard oil, groundnut oil, and I may add rice bran oil. So these are the 4 sources of oil which are very good in MUFA, which seems to be the best oil that we have. Coming to PUFA, PUFA, if you might remember, causes decrease in the bad cholesterol, but unfortunately also causes decrease in the good cholesterol. So if you have an oil which is solely PUFA and you don't use any other oil, then what will happen is you will end up with very low HDL values. You see in some of the populations HDL value of 35, and you ask them and they would say that we are having only safflower or sunflower oil or soya bean oil as our major oil in our diet, and that is what happens with that. LDL comes down, but HDL also comes down. So that is the big problem. And but there is one type of PUFA, that is N3 PUFA, which is very good for outcomes. Other type of PUFA, N6 PUFA, is not very good, but one type of PUFA, that is the N3 PUFA, can reduce the triglyceride and actually reduce the risk of sudden cardiac death, arrhythmias, myocardial infarction, and blood clotting. So if you have to consume PUFA, then you should try to consume N3 type of PUFA, and we'll come to that later. What about saturated fatty acid? Well, the saturated fatty acid may not be as much of a villain as it was thought, and the reason is that while it increases the bad cholesterol, it also increases the good cholesterol. And so that is something good about saturated fatty acid in a way, but the problem is that if you cook the whole diet, whole meal in saturated fat with deshi ghee or coconut oil, then the problem is that bad cholesterol will increase to a great extent, and therefore using only saturated fats in your diet could be harmful. If you have to use saturated fat, then they should be combined with some other kind of fats as well. And the rich source of saturated fat, as you might know, is ghee, butter, and in South India there is use of coconut oil as well. But the worst type of oil to consume is the trans fat. And why? Because it increases bad cholesterol, but at the same time it decreases good cholesterol. So this is the worst kind of oil to have, and it should be definitely not used at all. If you can get trans fat to 0, it is very good. Some of the countries, including India, have now recommended trans fat of less than 1%. Because what is found is that even 2% increase in trans fat increases the risk of coronary artery disease by nearly 25%. So just 2% increase in trans fat can lead to increase in coronary artery disease. And therefore you hear of this kind of epidemic that happened in India. Once Vanaspati ghee was discovered, and people thought that this is a good substitute for ghee, deshi ghee, and people started using Vanaspati ghee a lot, and then that epidemic of coronary artery disease struck in India. I'm not very sure about Bangladesh. I'm sure something like this might have happened here as well. And because just 2% increase of trans fat can increase the risk of coronary artery disease by 10 times that amount. So this is really a very bad kind of oil. And what is the good source of trans fat? Number 1, Vanaspati ghee. Number 2, reuse of oil. If you keep using the same oil again and again, and that very often happens in these outside eateries, dhabas, and all those kind of street foods, where they use only the same oil again and again, and it smokes and everything happens, and that is the worst kind of oil because it gets converted into trans fat, and that is the most harmful thing to do. So, you know, this meta-analysis, interesting meta-analysis, if you see, all kinds of oils are either neutral, and as I said, N3 PUFA is actually beneficial, and MUFA is also beneficial, but the only oil that is the worst kind is trans fat. So this is something which should be avoided at all costs. Now coming to the second important thing, and often ignored, because people focus more on oil and they don't focus on carbohydrate. And carbohydrate can be a worse sinner compared to fat in many of the situations. And it has been found that if you replace saturated fatty acid with carbohydrate, you have a serious adverse effect. So you would think that if you replace deshi ghee with lot of sugar, then it might not be that harmful, but the reality is that it is actually worse than even deshi ghee, the amount of sugar that you consume, especially the refined sugar. And carbohydrate intake, it has been found that if it exceeds more than 60% of total intake, like fat intake, if it exceeds more than 30% of the total intake, becomes very harmful, as I showed you. Likewise, if carbohydrate intake increases more than 60% of the intake, then it can be very helpful, and it has been associated with total and cardiovascular mortality. There are various reasons why carbohydrate is so bad. The prime reason being that carbohydrate ultimately gets converted to fatty acids. Because it cannot be stored as carbohydrate, it gets converted into fatty acid, and then it is like bad effects of both carbohydrate and fatty acid. Other thing is that it can lead to obesity, and the third thing is that hyperglycemia itself is toxic to the blood vessels. So all these three things create an impact of carbohydrate. So coming to the third food item that I would like to discuss is about fruits and vegetables. Very interesting study, nursing health study found that actually fruit and vegetable intake increased could reduce the risk of cardiovascular risk. And this is the interesting study. So if the amount of food and fruits and vegetables in the diet increases, then the risk of cardiovascular disease decreases. The question is how much to consume. So that is the question, how much is enough? And it has been found that a balanced diet contains 3 to 4 servings of fruits, vegetables and legumes daily, which can lead to marked reduction in mortality. So now what type of vegetables to consume is also very important. It has been found that fried and overcooked vegetable is not good. Actually, it is the raw kind of vegetable that appears to be more protective compared to cooked vegetables. And this study shows you just that. And then the other thing that can be very useful is legumes. That is like you have this ankurit chole, and I don't know what you call chole, but I think chana or something you call. And also those dals which have got, which get the fermentation, these starting of germination. Those kind of things are very good, and they can actually reduce mortality. So a cup of legumes or cup of chana before the meals, which is ankurit chana or something like that, that is actually very good for reducing the total mortality. Dietary fibers is also something, this study shows you well, that dietary fiber, if you increase the dietary fiber by any way, so you use whole grain atta, you use a whole grain, whole wheat bread, something like that, then that can reduce the cardiovascular risk as well. What about fish? So a lot of studies, and what it shows is that intake of 20 to 40 gram per day, or at least twice per week, can markedly reduce the risk of coronary artery disease, especially if the fish is rich in omega-3 fatty acid. Unfortunately, I think the fish that we get here is not very rich in omega-3 fatty acid. I believe hilsa is good in omega-3 fatty acid, but other than that, seafood like shellfish, like prawns, etc. are rich, and salmon is something which is very rich in omega-3 fatty acids. So these are the kind of fish which if you consume, then it is very good. Coming to what about the vegetable source? Do we have to get omega-3 fatty acid only from fish? Because a study showed that if you supplement by capsules omega-3 fatty acid, it doesn't help. The omega-3 fatty acid has to come from dietary source. So is fish only the dietary source? There is some evidence that some even vegetable foods can supply this omega-3 fatty acid, like mustard oil, flax, and soy. So these are some of the things that are rich source of omega-3 fatty acid, and they contain something called alpha-linoleic acid, which gets converted into omega-3 fatty acid in the body. But what about diets? So we hear of these very, very low-fat diets, keto diets, low-carbohydrate diets, etc. The reality is that none of these diets have shown any long-term benefit, and the reason is that they cannot be sustained for a long time. So that is why, you know, these diets are all fads, and they just waste money, and they probably don't lead to any weight reduction, and certainly not any improvement in life expectancy. Now coming to the second point, exercise. Now exercise has good effect on lipid parameters. So a regular exercise, about let us say 20 to 30 minutes, at least 30 to 40 minutes per day for 5 days a week, a moderate intensity exercise, or you may even say that increased physical activity, let us say more than 10,000 steps per day. If you can count your steps, more than 10,000 steps per day can have a good impact on lipid parameters, decreased triglyceride, decrease LDL cholesterol and increase HDL cholesterol. So decrease bad cholesterol, increase good cholesterol, and therefore they have good relation on lipid parameters. And if you can combine exercise with weight loss, then a marked benefit can be achieved in the basically coronary artery disease risk. What about impact of exercise on obesity and diabetes mellitus? It can reduce the incidence of obesity and diabetes mellitus as expected. Impact on coronary artery disease, we saw the impact on lipid profile, that it decreases the bad cholesterol, increases good cholesterol. But what about direct impact on coronary artery disease? Exercise and increased physical activity. As I said, about 10,000, at least more than 7,000 steps per day, ideally 10,000 steps per day, can markedly reduce the risk of coronary artery disease. Now, what about weight loss? So certainly weight loss has been found useful in reduction of blood pressure, and it has been found that just simple weight loss, if you can lose 10 kg weight, then the blood pressure can come down by 6, systolic 6 and even diastolic 6 millimeters of mercury. So just weight loss. Then cigarette smoking, I think I don't need to say anything. It's obviously important, and stopping cigarette smoking can lead to about 36% risk reduction in cardiovascular related mortality and 32% reduction in recurrent myocardial infarction. So it can actually reduce the risk of myocardial infarction as well. Now coming to, the situation in South Asia, and we gathered here because of the South Asia problem. We know that coronary artery disease strikes 10 years early in South Asians. Heart failure also strikes 10 years earlier in South Asians, and diabetes also is now found to strike 10 years earlier in South Asians, at least of Indian types. So what about these things? What about why is this so? And one of the reasons is that in Indians there is a very high carbohydrate content in South Asian diets, and it is estimated that in many of the diets nearly 3/4 of the calorie, that is 75% of the calorie, comes from carbohydrates. Whereas we know that more than 60% of calorie coming from carbohydrate can be very harmful, but in South Asian diets nearly 3/4 or even more of calorie comes from carbohydrates. So that is one problem. The other problem is that, as I said, carbohydrates account for 70% of total energy. The other problem is that we have moved from high fiber diets like coarse grains like millets, barley, sorghum, maize, etc. And we have moved from them into highly refined grains like wheat and rice. And that is another problem, that you reduce the fiber content of the diet. Then we have started including processed foods in our diet, salted snacks, prepared sweets, and animal products, etc. They are all processed food, and they can increase the risk. Another sad aspect is that mustard and groundnut oil, which were the traditional oils, which were rich in MUFA, I'm just going to finish, have been replaced by palm oil, soybean oil, and safflower oil, which are rich source of PUFA and not MUFA, and that is another problem. And then there is finally the fad about olive oil. Then a talk about vegetarianism. We think that in South Asia we consume a lot of vegetable. The reality is that the vegetable and fruit consumption is lowest in South Asia compared to rest of the world. And we use highly starchy vegetables, highly cooked, and lower in legumes and high in dairy. So this is the basic problem. And the other thing is that, as I discussed earlier, raw kind of vegetable or raw fruits are useful. But in South Asia, we have a habit of killing the vegetables by overcooking, by frying, deep cooking, overcooking, and that is another problem with the South Asian diets. So what can we do? I think some of the things, of course, consume less carbohydrate, eat more fish if possible, eat plenty of fruits and vegetables, a diet rich in grains and fibers, cook the food at home and avoid outside food, reduce deep fried food, avoid use of trans fat, no repeated cooking, and not cooking to an extent that the oil starts smoking, because at that point it starts converting into trans fat. And so these are some of the things. Regarding which oil to use, I think a balanced oil is best, but I've just given some of the options: mustard oil, rice bran oil, groundnut oil, or a combination of oils can be a good combination. If you see that the ratio of MUFA, PUFA and SFA should be 1:1:1. So 1/3 could be MUFA, 1/3 could be PUFA, and 1/3 could be saturated fat. So if you can use a combination of oils to balance, then that is good. What about olive oil? Can I have, this is the last slide actually. So can I have this slide or no? Okay, then I finish. Thank you so much. Okay, so they have shown. Now mustard oil, as I said, is very low in saturated fat. It's high MUFA content, 70%. And also it contains a lot of omega-3 fatty acids. So this is, I think, the ideal oil to have. But olive oil, the problem is, while it is very rich in MUFA, if you heat it, it starts smoking at a lower temperature. So especially extra virgin olive oil is not good for Indian kind of cooking. You can use it on salads to sprinkle, but you can't use it for Indian type of cooking. Thank you so much for your kind attention.
Thank you, sir, for a very elaborate discussion on diet and exercise. I'm thinking what we are doing till we are very much habituated taking rice, oils, and habituated doing sedentary work. So I think it is the time to change our food habit and lifestyle. Our next presenter is, we will have more discussion at the end of our session. Our next speaker is Professor Dr. Abdul Shafi Mojumdar sir. Sir will talk on lipid management in cardiovascular protection.
Thank you, sir. My honorable chairpersons, in the next few minutes, I will be talking about the lipid management in the cardiovascular prevention. A part of my lectures has been delivered by Professor Sharma about the diet and other things, which is included in the lipid management. What is the prevention scope of the cardiovascular disease is very high, because the efforts to prevent the onset of the cardiovascular disease is monumental importance. Because from a public policy and global health policy, we can prevent the disease. This is the unique of the cardiovascular disease. In most cases, there are very few preventable factors, but in the cardiovascular, atherosclerotic cardiovascular disease, there is many factors that can be prevented. There is a primordial prevention, there is the prevention of the, before the risk factors or the risk factors develop. The primary prevention is the prevention of the risk factors, and the secondary prevention, the prevention of the events when the atherosclerotic events takes place already. So these are the three ways to prevent the atherosclerotic cardiovascular disease. Another thing is the early prevention is very important. You see the fatty sticks and fibrous plaques in the aorta and the coronary arteries develop very early in the age. অনেক সময় আমরা মনে করি যে ছোট বাচ্চা এদেরকে আমরা হয়তো ফ্যাট বেশি খাক এতে অসুবিধা নাই, কিন্তু that is not right. ASCVD risk factors such as hypercholesteremia, hypertension, obesity track from the childhood, adulthood to adulthood and predict the development of the subclinical atherosclerosis. কাজেই এবং টাইম অফ দি এক্সপোজার ইজ অলসো গ্রেটার ইন দি ইয়াঙ্গার পারসনস, যে তাদের এক্সপোজার টু দি রিস্ক ফ্যাক্টরস উইল বি লঙ্গার। কাজেই লোয়ার ফর লঙ্গার ইজ বেটার। আগের থেকে আমাদেরকে অ্যাট দি আর্লি এজে আমাদেরকে প্রিভেন্টিভ মেজারমেন্ট নিতে হবে। তাহলে লাইফস্টাইল ফ্যাক্টর অ্যাসোসিয়েটেড উইথ দি লোয়ার ASCVD is already detailed
by the Professor Sharma is the healthy dietary pattern, regular physical activity, abstinence from the tobacco, avoidance of the excess alcohol intake, stress management, and adequate sleep quality and quantity. Sleep talk is a very important part of the risk factors. এটা খুব বেশি হয়তো বলার দরকার নাই, already been detailed. Total fat intake should be 25 to 35% of the total calories, and saturated fat should be less than 7%. I can echo the assertion which has been made by Professor Sharma is that আমরা যেটা কোলেস্টেরল নিয়ে যে আমরা এত চিন্তা করি, আমরা কোলেস্টেরল খাবো কি খাবো না, which has been, আমি সবসময় বলি যে এই খাবারটা only 30% of the fat is from the exogenous source, and others are the endogenous, that is the prepared from the carbohydrates and other within the body, in the liver. So আমাদের খাবারের যে বড় বড় সিল তৈরি করা হয়, which is not very logical. And choosing the more plant-based food patterns is very important. That is the legumes, pulses, এটা already বলা হয়েছে. Eating fish is also important. Or processed food or ultra processed food should be avoided. এখানে একটা এই কিছুদিন আগে এটা বের হয়েছে ইউরোপিয়ান হার্ট জার্নালে, যে আমাদের কি কি বেশি খেতে হবে। ভেজিটেবলস, ফ্রুটস, হোল গ্রেনস, lean protein foods, nuts, seeds, legumes, unsaturated fats or non-tropical oils. This is the increase, and this is the red sign. Saturated fat and tropical oils, salt, processed meats, ultra-processed foods, refined grains, added sugars. Just a few weeks back, it is published in the European Heart Journal. এখন লিপোপ্রোটিনকে আমরা যদি টার্গেট করি, the causal role of the LDLC and other ApoB containing lipoproteins is confirmed, established. কাজে আমাদেরকে এই LDLC করতে হবে, কমাতে হবে। Relative reduction in the CVD risk is proportional to the absolute reduction of the LDLC. Mind it. যত আমরা অ্যাবসলিউটলি কমাতে পারবো, আমাদের রিলেটিভ রিডাকশন তত আমাদের করবে, and there is no evidence of the lower limit for the LDLC value. There is no J curve যে এত দূর কমে গেলে আমাদের বেনিফিটটা চলে যাবে, হার্মফুল হবে. There is no J curve. And absolute benefit of lowering LDLC depends on the absolute risk of the SCVD and the absolute reduction of the LDLC. So even a small absolute reduction on the LDLC may be translated in the greater benefit. এখানে আমাদের ESC guideline for the prevention last year যেটা বের হয়েছিল, class 1 high intensity statin is prescribed up to the highest tolerated dose to reach the LDLC goal set, এবং very high risk যাদের, এটা আমাদের কিন্তু ESC guideline on the prevention. It is different from the ESC guidelines on the lipid management. Class 2A, very high risk, LDLC goal is less than 55. And class 2A, high risk, LDLC goal is 70 milligram. And the class 1 is if the goals are not achieved, then we can combine the statins with the ezetimibe. And class 2B is we can add the PCSK9 inhibitors even in the primary prevention. If statin-based regimen is not tolerated, then we can use the ezetimibe. If the statin-based regimen at any stage or any doses, then we can use the PCSK9 inhibitors. And if the goal is not achieved, then we can use the statin combination with the bile acid sequestrant, class 2B, and premenopausal women planning for pregnancy, the statins are contraindicated. Optimizing the lipid management. This is the cardiovascular risk assessment is the foundation of the primary prevention. যেটা আমি বলছিলাম যে স্কোর ইন দি ইউরোপ অ্যান্ড দি আমাদের পুল equation, risk estimation or equation in the USA, pool cohort equation in the USA. এটা হলো scoring system which is widely used by the European society and the American society respectively, কিন্তু আমাদের দেশে নাই। কিন্তু আমাদের দেশে যেটা করা যেতে পারে, আমরা ভেরি হাই রিস্ক বলতে কি বুঝি, হাই রিস্ক বলতে কি বুঝি, মডারেট রিস্ক বলতে কি বুঝি এবং লো রিস্ক বলতে কি বুঝি, there is some points in favor of which I will touch later on. এটা গেল more intense pharmacologic treatment to high risk primary and secondary prevention patients. কিন্তু আমাদের এই রিস্ক স্ট্রাটিফিকেশনের ইম্পর্টেন্স হলো statin is not associated with harmful effect, is not associated. There are some harmful effects with these statins. Because we have to choose the patients for whom for the primary prevention we have to start these statins. Not for all the. যেমন আমরা indiscriminately we should not use the aspirin, statin as we should not indiscriminately use the aspirin. The same thing. আরেকটা যেটা একটু লাস্ট একটা প্রেজেন্টেশনে ক্যালসিয়াম স্কোরের কথা আমি বলছিলাম যে সিএসসি টেস্টিং এনি স্কোর অ্যাবাভ দি জিরো ডেমনস্ট্রেট অ্যান্ড ইনক্রিজ এসসিভিটি রিস্ক ইফ দ্যার ইজ সাম ইন্টারমিডিয়েট রিস্ক স্কোর। আর আমাদের মতো দেশে যেখানে রিস্ক স্কোর নাই আমরা হয়তোবা এই ক্যালসিয়াম করোনারি ক্যালসিয়াম স্কোরটাকে আমরা হয়তোবা ইউজ করতে পারি টু স্ট্রেটিফাই দি রিস্ক অফ দি পেশেন্ট। তাহলে আমাদের প্রাইমারি প্রিভেনশনের কি রিস্ক ফ্যাক্টরসটা কি কি? হাই এসসিভিটি রিস্ক, যেটা আমাদের দেশে নাই, আমরা থিওরিটিক্যালি বলতে পারি। সিভিয়ার অ্যামাউন্ট অফ দ্য করোনারি আর্টারি ক্যালসিফিকেশন উই ক্যান আইডেন্টিফাই ইন আওয়ার কান্ট্রি। The diabetes, especially if requiring insulin, long standing or associated with other complications, family history of the premature CVD, the elevated TG or low SDL, elevated LPA, lipoprotein A, especially at high levels. These are the increased risk, and there are some risk enhancing factors. Chronic kidney disease, chronic inflammatory conditions such as psoriasis, rheumatoid arthritis, these are also the risk enhancing factors for the atherosclerotic cardiovascular disease. History of the premature menopause, history of the pregnancy associated complications such as eclampsia during any pregnancy is a risk factor for the atherosclerotic cardiovascular disease for the woman, metabolic syndrome, and the ankle brachial ratio, which has been discussed a few minutes back. And আমার মনে হয় এগুলি দরকার নাই। Weight loss, the regular physical activity, these are all been touched by the previous speaker. I'm not going to, just this point. Role of dietary cholesterol is not conclusive, but advisable not to exceed a daily cholesterol intake of 300 milligram, 2 eggs a day. আমার মনে হয় এটা আমরা যাই। These are all the things. For it, this is important. For every 1 minimal reduction of the LDL-C, there is a 23% risk reduction. 1 minimal reduction of the LDL, তার মানে around 40 milligram LDL risk reduction, 23% risk reduction, and 21% for the cardiovascular plus stroke. That's very important to reduce the statin in a selected group of patients. এখানে আমাদের কথাগুলি আমরা বলছি, কাজে I am not going to এটাই বারবার যে অ্যাবসলিউট রিস্ক রিডাকশন উইল বি মোর এট হায়ার বেসলাইন এলডিএল লেভেল। আমাদের এলডিএল লেভেল যত বেশি থাকবে আমরা তত রিস্ক রিডাকশন করতে পারবো স্টাটিন দ্বারা। এলডিএল লেভেল যত কম থাকবে রিস্ক রিডাকশন, দ্যার উইল বি অ্যাবসলিউট রিস্ক রিডাকশন, কিন্তু রিলেটিভ রিস্ক রিডাকশন খুব কম হবে কিন্তু লো রিস্ক গ্রুপে। আর আরেকটা হলো দিস অলসো টু বি কেপ্ট ইন মাইন্ড ইজ দ্যাট দি ফাস্টিং ট্রাইগ্লিসারাইড মোর দেন 150 milligram is the marker of the increased risk. এটা তো আমরা অনেক সময় বলি না। This is very important. And low SDL level, এটা যেটা আমরা বলি ভালো ফ্যাট খারাপ ফ্যাট, low SDL is not a risk factor, it is a risk marker. It is a bystander of the high triglyceride level, bystander. It is not by itself is a risk marker. এটা খুব রিসেন্টলি US প্রিভেন্টিভ সার্ভিসেস টাস্ক ফোর্স রিকমেন্ডেশন খুব রিসেন্টলি এটা আসছে, আমার মনে হয় যে ইন জুলাই অর সামথিং, যে এখানে 40 to 75 years statins in moderate intensity, moderate benefit, and if 10-year risk is 7.5 to 10%, statins in selected cases small benefit, age more than 76 years, insufficient evidence to prescribe these statins. এটা তিনটা পয়েন্ট মেইনলি এখানে আসছে। The clinician evaluate both the presence of the CVD risk factors and initiate these statins. কারণ প্রত্যেকটা ইন্ডিভিজুয়ালাইজড করতে হবে, আমাদেরকে জেনারেলাইজ করার স্কোপ নাই। আমার মনে হয় এখানে এই কথাগুলি বলা হয়েছে। মি স্কিপ, এটা একই কথা, এটা অন্য অন্য জায়গার থেকে নেওয়া, যে এসিসি বলছে লেভেলস অ্যাট হুইচ টু স্টার্ট দি স্ট্যান্ড মোর দেন 4.9 মিনিমলস ইরেসপেক্টিভ অফ দি রিস্ক, তার 190 মিলিগ্রাম আমরা যেটাকে 4.9 মিনিমলস, ইএসসিও তাই বলছে, কিন্তু নাইস বলছে যে ওটা স্কোরিং করে তারপরে দেওয়ার জন্যে। আর রিকমেন্ডেড স্ট্যাটিস, নাইস বলছে যে অ্যাট্রোভাস্টাটিন 20 মিলিগ্রাম ইজ দি ড্রাগ অফ চয়েস, কিন্তু ইএসসি এবং এসএসসি কোনো চয়েস নাই। যদি আমরা জানি অ্যাট্রোভাস্টাটিন এবং রোসুভাস্টাটিন, দিস টু agents of the statins are better for the primary prevention than the other statins. এই যে এটা আমি একটুখানি আমাদের যারা জুনিয়র ডাক্তার আছে তাদেরকে একটু দেখার জন্যে, যদি আমরা স্কোরিং করতে পারি না, কিন্তু ভেরি হাই রিস্ক মানে কি, এটা কিন্তু ফ্রম দি ইউরোপিয়ান হার্ট জার্নাল থেকে নেওয়া হয়েছে, ইউরোপিয়ান সোসাইটি গাইডলাইন থেকে। Very high risk মানে diabetes mellitus with target organ damage or at least 3 major risk factors or early onset of the type 1 diabetes mellitus of long duration. এটা হলো very high risk. Severe CKD, the eGFR less than 30, a calculated score of more than 10. এটা তো আমাদের নাই, তাহলে আমরা এই দুটো দ্বারা কিন্তু আমরা হাই রিস্ক গ্রুপ আইডেন্টিফাই করতে পারি। আর ভেরি হাই গ্রুপ আর হাই রিস্ক বলতে মার্কলি এলিভেটেড সিঙ্গেল রিস্ক ফ্যাক্টরস, ইন পার্টিকুলার টোটাল কোলেস্ট্রল মোর দেন 310, the LDLC more than 190, blood pressure more than 180 and 110. This is one. Patients with diabetes without target organ damage, with diabetes mellitus more than 10 years duration, these are the high risk group. Moderate CKD 30 to 59, high risk group. তারপরে ক্যালকুলেটেড স্কোর। কাজেই even in the absence of the scoring system, আমরা ক্লিনিক্যালি কিন্তু we can judge the which patients are at high risk, which are the very high risk, which are the moderate risk, and who are the low risk. এটা একটু ক্লামজি, দেখে মনে হবে যে অনেক ক্লামজি, আসলে অত ক্লামজি না। এটা হলো আমাদের লো রিস্ক, moderate risk, high risk, and very high risk. These are the part of the primary prevention. I am very much concerned with the primary prevention because in the secondary prevention, in the established atherosclerotic cardiovascular disease, all the patients are at high risk or at very high risk. কাজে তাদেরকে স্টাটিন দেওয়ার ব্যাপারে কোনো কন্ট্রোভার্সি নাই, অথবা লিপিড লোয়ার করার জন্য কোনো কন্ট্রোভার্সি নাই। কন্ট্রোভার্সি অর ডিবেট ইজ দেয়ার ইন দি প্রাইমারি প্রিভেনশন। কাজে এই চার্টটা যদি, ইট ইজ অলসো টেকেন ফ্রম দি ইএসসি গাইডলাইন, অনেক সময় আমরা খেয়াল করি না। এখানে দেখেন লো রিস্কের এই যদি 116 to 190 মিলিগ্রাম যদি আমাদের এলডিএল হয়, তাইলেও কিন্তু আমরা আগে লাইফস্টাইল দেখব, তারপরে আমরা স্টাটিন থেরাপি দিব। ও যদি 190 বেশি হয় তখন আমরা স্টাটিন দিব। আর যদি দেখেন এটা যদি ভেরি হাই রিস্ক হয়, আমাদের 55 to 70 মিলিগ্রাম এলডিএল এর মধ্যে আমরা ড্রাগ থেরাপি দেওয়া শুরু করব ভেরি হাই রিস্কের বেলায়। এই চার্টটা ওই জন্য আপনারা এএসসি গাইডলাইন থেকে দেখে নিতে পারেন। দিস ইজ ভেরি গুড চার্ট ফর দি ক্লিনিশিয়ান। আর আরেকটা আমার একটু বলতে হয় যে টিজিকে টার্গেট করা, টিজেট এই রিডিউসিড ট্রায়াল আমাদের 2019 এই রিডিউসিড ট্রায়ালটা পাবলিশ হয়েছে। সেখানে দেখা গেল এলডিএল খুব কমানো 40 to 100 মিলিগ্রাম, আর টিজি 150 to 399. Icosapentethyl reduces the MACE by 25% comparing to placebo, which was the mineral oil. So icosapentethyl play a key role in the future recommendation for the prevention of the cardiovascular beyond the LDL lowering therapy with the study. আমরা যে এতক্ষণ শুধু স্টাটিন বললাম, in the futures or at the present time, the icosapentethyl may be have to be prescribed routinely for the primary prevention even. এখানে এটা অত মনে রাখার দরকার নাই। এটা বলা হয়েছে যে পিঙ্ক কালার হলো বেশি হার্ম, ইয়েলো হলো হার্ম ইকুয়ালস দি বেনিফিট, আর গ্রিন হলো বেনিফিটটা বেশি। এই দেখেন যত বেশি স্কোরিং হবে, এখানে স্কোরিং দিয়ে দেখেছে যত বেশি স্কোরিং হবে বেনিফিট তত বেশি হবে। স্কোরিং কম হবে, এই দেখেন এই লেভেলে হার্ম ইজ মোর দ্যান দি বেনিফিট। কাজে স্টাটিন যে আমরা হইলেই দিয়ে দিব তা চলবে না। এটা ম্যানদের বেলায়, উমেনদের বেলায় তারা একটা চার্ট করছে 2019-এ, সেই জন্য বলছে ব্যালেন্স করতে হবে যে আমাদের thresholds were lower for the atorvastatin and rosuvastatin যেটা বলছিলাম যে সরি আমাকে একটু দেখতে দেওয়া যাবে না আমার এইতে সামারিটা করে ফেলবো এখনই they are very strict না হ্যাঁ summary that's the summary atherosclerotic cardiovascular disease is a serious global health issue but the disease is preventable that is very important and primordial prevention by the physical exercise and the diet primordial prevention by the physical exercise and the diet the primary prevention is the lifestyle advice as well as lowering of the LDL and the recently also lowering of the triglyceride and the cost-effective assessment is very important for the consideration of the side effects lead to use of statins in low-risk group and less favorable. Karan, you are going to give the drug to a healthy persons. In the secondary prevention, no matter. The patient is already diseased patient, so you can use the drug. But in the primary prevention, patient is healthy. And you are going to try to prevent the disease. So you have to be very cautious whether you will start to use the statins or not. শুধু এইটুক মনে রাখলে হবে ডিএম পেশেন্টসের মডারেট ইন্টেন্সিটি স্টাটিন দিতে হবে ইন ডিএম উইথ এনি আদার রিস্ক ফ্যাক্টর হাই ইন্টেন্সিটি দিতে হবে এলডিএল 190 হলে হাই ইন্টেন্সিটি স্টাটিন দিতে হবে সিকেডি পেশেন্টস সিভিয়ার হলে হাই ইন্টেন্সিটি মডারেট হলে মডারেট ইন্টেন্সিটি কারণ জিএফআর এর জন্য উপরে নির্ভর করছে অ্যান্ড অ্যাসেসমেন্ট অফ রিস্ক এস্টিমেশন for patient without SCVD is recommended for the initiation and intensification of the statins and the other lipid lowering agents. I think it is the end of my slides. Yes. Thank you very much for the patient here.
Thank you, sir, for your excellent talk on lipid management. Our next presenter is Professor. Our next presenter is Professor Abdul Wadud Chowdhury, sir. Sir will talk on blood pressure management, a cardiovascular protection.
Thank you. My topic is blood pressure management in the cardiovascular protection. Let's have a look. The hypertension is one of the key beginners of all damages. That it starts with damaging the endothelium and ends up going up to end-stage heart disease. Now, the prevalence of hypertension has increased over the past 4 decades, particularly in a country like ours. And remember, 2/3 patients living in low-end to middle-income countries. So we are the kings and queens of patients of hypertension. And how much it is important? Look at this chart. Hypertension is the leading cause of death worldwide. Look at the graph. It's high above every risk factors. And 10.4 million deaths each year because of hypertension. And it leads to cardiovascular disease, ischemic heart disease, stroke, hemorrhagic stroke, other cardiovascular disease including aortic dissection or peripheral vascular disease and chronic kidney disease. Problem is 1 out of 2 people with hypertension doesn't know they have it because it's mostly symptomless, and so we call it a silent killer. The prevalence is higher in low to middle income countries, around 30% than compared to the high income countries. And Bangladesh studies have shown it's nearly 30 so far. And it has been attributed to this 30% of global deaths with a projection of 30% increase in worldwide. And look at that. Salt sensitivity, obesity, diabetes, metabolic syndrome, Western lifestyle, seasonal variation, and dietary habits, urbanization, BP variability, all these factors react interact synergistically with the results that the patient may or may not have a cardiac event or vascular event. We can say that many observational studies have shown office blood pressure, that means the pressure you are seeing in chamber or in a hospital, is an independent, continuous relationship with the incidence of several cardiovascular events. What are those? Stroke, myocardial infarction, sudden death, heart failure, peripheral arterial disease, as well as end-stage renal disease. And this is true for all ages and all ethnic groups. And systolic BP is a stronger predictor of events than diastolic BP, particularly after the age of 50 years. And in the elderly, pulse pressure has an additional prognostic role. Isolated systolic hypertension has particularly high cardiovascular risk. A continuous relationship has been also shown by 24-hour ambulatory blood pressure monitoring or home blood pressure monitoring, not only office BP, and if you have higher pressure, a little bit more than at your home, it's also harmful for you. What happens? Hypertensive, if you are chronically hypertensive, it causes cardiac hypertrophy. And that itself is an independent risk factor for myocardial infarction. Left ventricular hypertrophy is associated with increased oxygen demand. And that leads to development of new arterial vessel collaterals to supply the myocardium. The collateral circulation is driven by the pressure gradient, is more effective in the subepicardial layer because the coronary artery is in the superficial part of the heart, over the heart muscle layer. So they are better in there than the subendocardial layer. And therefore, it results in the subendocardial layer is more exposed to ischemia infarction. And that's why non-STMI is much more common than STMI. During an ischemic event, reduced systolic blood pressure and decreased valve tension of the ischemic area results in patency of small vessels giving some blood supply to the ischemic area. But if there is large reduction of the diastolic blood pressure, that leads to more ischemia despite the lack of total vessel occlusion. There are some vessels that are patent, but because the pressure is dropped down too much after a massive MI, that will not serve the area intended. The relation between hypertension and myocardial infarction can be mainly explained by underscoring the two key factors. They share the common risk factors, like genetic risk profile, insulin resistance, sympathetic overactivity, and excess vasoactive substances, particularly those active in the RAS system. And hypertension is associated with accelerated atherosclerosis, which again contributes to the progression of myocardial infarction. That's why hypertension and myocardial infarction হাত ধরাধরি করে চলে. The pathophysiological factor, genetics and other things, insulin resistance, hyperglycemia, there is endothelial dysfunction, mechanical stress, permeability issues, left ventricular hypertrophy, all this led to unstable plaque rupture, atherosclerosis goes to there, and that leads to myocardial infarction. Sympathetic activity or over vasoactive substances, all those contributes that may result in acute myocardial infarction. And look at this graph. If you have a pressure below 100 systolic, that leads to increased risk. If you have pressure more than 140, there is increased risk for myocardial infarction. Again, for the diastolic pressure, there's a little bit different. But again, if it's too low, you have higher risk. If it is higher than 90, you started having higher risk. What about heart failure? Chronic hypertension causes the structural and functional changes in the heart that ultimately lead to heart failure and cardiac remodeling and heart failure, which further increases the mortality and morbidity. Treating high BP intensely prevents and reverses myocardial changes in patients at risk of heart failure. If you have a patient hypertensive heart LVH is there, you control the blood pressure intensely. After 1 year, you find that the LVH has regresses. But when the patient has heart failure, it's difficult to tell which level of blood pressure will be optimal for that patient. You cannot generalize it. You have to have individualized response. Now, high blood pressure increases the left ventricular afterload and peripheral vascular resistance, and prolonged exposure to that leads to pressure and volume-mediated left ventricular structural remodeling. Now, this ventricular hypertrophy initially is a compensatory mechanism, and that preserves the cardiac output and delays cardiac failure. But the remodeled left ventricle is likely to decompensate over time, and that heart failure will ensue. That develop as a consequence of increased LV stiffness and the presence of diastolic dysfunction. Now, we forget that 50% of the heart failure patients actually have diastolic heart failure, so-called the heart failure with preserved ejection fraction. So, and that are mostly related to hypertension. There's a cartoon showing the same thing. In one hand, we have systolic dysfunction, but diastolic dysfunction that develops over time, particularly related to LVH, that is a result of prolonged hypertension. And again, the hazard ratio, if you have lower, too low, it's bad for you, higher, bad for you. Over 140 is bad. Look at the diastolic pressure, same. Below 60, not good. Over 90, not good. মধ্যবর্তী এলাকাটাই উত্তম. And how do we treat it? A little bit complicated, because we know that it's important with respect of progression and patient prognosis. Most effective heart failure medication lower BP to some extent. So we can assume that there is a close relationship that exists between blood pressure and heart failure outcome. In the paradigm study have shown that the benefit of sacubitril valsartan over enalapril was still evident in patients where the systolic pressure is less than 120, but it is less than those having systolic pressure more. The lower the pressure, the benefit of ARNI is lower. Higher the initial pressure, the benefit of ARNI is better. When the higher the degree of risk, the greater the benefit of that particular intervention. What about stroke? Hypertension is the most prevalent risk factor for stroke. That has been reported that 64% of patients with stroke have hypertension as a contributory factor. They exhibit higher risk for both ischemic and hemorrhagic stroke compared to patients without hypertension, particularly in those patients who have poor blood pressure control, and particularly those patients who take their medicine irregularly. The risk of stroke follows a linear curve with 6 to 7% increased risk per 10 millimeter increase in systolic blood pressure. And somebody was asking before that why the systolic pressure is so much important. Because after 50, it's the pressure that actually correlates more with the cardiovascular events. Again, the hazard ratio, again, the similar pattern. And the best level of risk reduction is at that level, between systolic pressure 110 to 120, ideal. Again, the diastolic pressure, same. If you have too low diastolic pressure, you will have higher chance of stroke. If you have higher, more than 160, you have very high risk compared to those with a normal level. This is a slide very clumsy, but what we want to say, that's the current clinical guidelines suggesting for patients how to approach for patients with ischemic stroke or hemorrhagic stroke. And initially in ischemic stroke, because the response of higher blood pressure after a stroke is actually a protective phenomenon. The body is trying to push some blood in the ischemic area. So it should not reduce the pressure too much, particularly in ischemic stroke, in the initial few days. But later on, in hemorrhagic stroke, you try to reduce it to some extent, but not too much. But afterwards, the best pressure level that we want to achieve when the patient is discharged, if he survives the initial event, the target should be around 130/80, around 130/80, not too low, not too high. Hypertension with arrhythmia. Patients with hypertension have 1.7-fold higher risk of developing AF than non-hypertensive individuals, sudden cardiac death. SCD constitutes 27 to 60% of all cardiovascular death in a hypertensive patient. And it is related over time. The patient who die of SCD compared to the who survived have been shown to have higher pressure. Again, if we call this is a all-cause mortality, again the similar picture. Hypertension is CKD. This is a study, over 23,000 men and women were involved, which shows that the adjusted hazard ratio of developing CKD among women was 2.5 for normal BP, 3 for high normal BP, 3.8 for stage 1, 6.3 for stage 2, that's the ESC type classification, and 8.8 for stage 3 or 4 hypertension compared to the individuals with optimal BP. So hypertension has a graded relationship with the development of CKD. Peripheral arterial disease is a risk factor for vascular disorder. We know that 35 to 55% of patients with peripheral arterial disease show hypertension. White coat hypertension is associated with increased risk of cardiovascular event. These are some factors we should remember, that when we treat it, still 2 out of 3 patients have uncontrolled BP. And treating and not controlling BP has a very bad effect, dramatic consequence. These 2 lines show one, they do not have hypertension, or those have treated and very well controlled. These 2, not taking any drugs or uncontrolled. Very gradual, very dramatic differentiation between these 2 for all, CVD, heart disease, cardiovascular disease. If you treat it, please treat it very well, because poor control is equivalent to no treatment at all. We should remember, if you're in doubt, 24-hour blood pressure measurement is a good thing because it's a better cardiovascular risk predictor. And BP variability. They have highest level of control, least variability, and lowest amount of cardiovascular event. So, increasing blood pressure variability is a strong predictor of cardiovascular morbidity. So, we should aim to include drugs that actually reduces this variability. We should also remember central blood pressure predicts cardiovascular mortality better than brachial BP, and that's particularly true for stroke. That's why atenolol increases the chance of stroke, amlodipine reduces it because it reduces the central pressure. These are outcome trials, I will not show it. We should remember that, look at this. ACE inhibitors have consistently shown to have greater benefit than ARBs. The summary is, hypertension is the strongest risk factor for almost all different cardiovascular diseases. The prevalence of hypertension as well as cardiovascular risk are increasing day by day. Blood pressure control is one of the important factors to reduce cardiovascular morbidity and mortality. Consistent blood pressure controlling, the term is consistent blood pressure controlling, is a key factor for any kind of cardiovascular health. Thank you, dear audience. Thank you all.
Thank you, sir, for a very informative presentation. We learned a lot. Our next presenter is Dr. Professor Indrajit Prasad. Sir will talk on management of diabetes and cardiovascular protection.
It's a matter of great pleasure and honor to be invited in this prestigious platform of IPDI to present my topic, cardiovascular protection in diabetes. As I'm an endocrinologist, so I'll be talking diabetes, how to protect our patients of diabetes from adverse outcomes. Actually, what we see that the diabetes leads to bad cardiovascular outcome. But the thing is that this is called common soil hypothesis. যে একই জমির ফসল মানে হচ্ছে যে রিস্ক ফ্যাক্টরের কারণে ডায়াবেটিস হচ্ছে আসলে একই রিস্ক ফ্যাক্টরের কারণে কার্ডিওভাস্কুলার আউটকাম খারাপ হচ্ছে। সো এটা হচ্ছে যে লাইক একই রকম এনভায়রনমেন্টাল ফ্যাক্টর এবং একই রকম জেনেটিক ফ্যাক্টর আসলে শেয়ার করে এই কার্ডিওভাস্কুলার ডিজিজ এবং ডায়াবেটিস। সো ধরে নিতে হবে শুরু থেকেই দুটো একসাথে আছে, সেটা ধরেই আমাদেরকে আগাতে হবে এবং রিস্ক ফ্যাক্টরগুলো ম্যানেজ করতে হবে। So traditionally, we can see that overweight and obesity increase LDL, ApoB, decrease HDL, and triglycerides. Our Shafi Mozumdar sir was wondering in the last session that whether we can measure the ApoB level. I have talked to the director of National Institute of Laboratory Medicine. He has just told me that as it's very much urgent for cardiologists, we are going to introduce the ApoB level in Bangladesh very soon. And age, sex, risk factor, family history is a big risk factor, inflammation, hypercoagulation, elevated blood pressure as mentioned by Professor Wadud sir, and smoking is a great risk factor, physical inactivity, and ultimately the insulin resistance syndrome or the metabolic syndrome is a big risk factor for this cardiovascular outcome. And you know what we can do, আমরা কি করতে পারি এই কার্ডিওভাস্কুলার আউটকামকে ভালো করার জন্য? এক নম্বর হচ্ছে যে গ্লাইসেমিক কন্ট্রোল করতে পারি। আপনারা জানেন যে টার্গেট হচ্ছে যে 7% for all average uncomplicated non-pregnant patients. The average target is 7%. If we can achieve, then it's a great matter of thing. And if we cannot achieve 7%, doesn't matter. If you reduce 1% from 13% to 12% to 12% to 11%, you can reduce 20% of the cardiac death. So it's a big thing. 1% reduction of the HbA1c is of great value. Lifestyle modification already. Our previous speakers, like dietary modification, very nicely mentioned, weight management, smoking cessation, and blood pressure lowering has been mentioned by our Honorable Professor of Cardiology, Wadud sir, and dyslipidemia management is very much nicely and clearly mentioned by our Shafi Majumdar sir. But the thing is that matter of frustration all over the country and my center as well, the overall control of diabetes is very poor. Like only 8.7% of my patients in my center is controlled, and overall in the total Bangladesh actually more than 85% patients are uncontrolled. So the basic things, we are searching for compelling indication of different kind of drugs that will lead to good cardiovascular outcome. So thing is that একটা বিড়ালের যদি গল্প বলি যে বিড়াল ভালো না খারাপ, প্রথম চিন্তা করতে হবে যে বিড়াল দেখতে সুন্দর তুলতুলে নাকি ঘরের শোভা বাড়ায় নাকি বিড়াল ইঁদুর ধরতে পারে। মানে যে কোনো একটা ড্রাগের যদি আপনি মনে করেন যে এটা কেমন কাজ করবে অ্যান্টি ডায়াবেটিক সুগার কমায় কিনা, সেটা হচ্ছে যে প্রাইমারি থিং। সো যে কোনো মেডিকেশন আসলে চুজ করার আগে আপনাকে চিন্তা করতে হবে যে এটা আপনার ডায়াবেটিস কতটুকু কমাবে। সো বেসিক থিং ইজ ফার্স্ট। তো আপনি বার্গার খেয়ে পেট ভরতে পারবেন, কিন্তু অনেক টেস্টি কোনো সস খেয়ে কিন্তু আপনার খুব পেট ভরবে না, এবং যে ফুডের যে ইয়েটা মানে আলটিমেট টার্গেট যে আমার ক্যালোরি নিতে হবে সেটা কিন্তু হবে না। সুতরাং সব কিছু আমাদের চিন্তা করতে হবে। সো আনফর্চুনেট ইজ দ্যাট 1 in 3 of all people with type 2 diabetes establish cardiovascular disease, and 2 out of 10, এটাও একটা আয়রনি দ্যাট যেসব ড্রাগ প্রুভেন আছে যে এই ড্রাগগুলো আমাদের কার্ডিওভাস্কুলার আউটকাম ভালো করে, সো 10 জনের মধ্যে মাত্র 2 জন সেই ড্রাগগুলো পাচ্ছে যেগুলো আসলে কার্ডিওভাস্কুলার বেনিফিট প্রুভ করা আছে। সো এটাও একটা প্রবলেম আমি মনে করি। আর আমাদের প্রিভিয়াস স্পিকার বলে গেছেন যে সাউথ এশিয়ান যে ক্যারেক্টারিস্টিক্স, আমাদের এখানে ডায়াবেটিস হয় খুব আর্লি, লঙ্গার ডিউরেশন, হয়ে যায়, ডায়াবেটিস যেহেতু আর্লি ডেভেলপ করে সেজন্য কমপ্লিকেশন বেশি হয়, এবং কম্পারেটিভলি লো বিএমআইতে অনেক মোটা হয়ে মানুষ ডায়াবেটিস হয়। এটা একটা কমন স্টাডি আছে যে যাদের বিএমআই 27-এর বেশি তাদের ডায়াবেটিস হওয়ার সম্ভাবনা, যারা স্লিম তাদের থেকে 10 গুণ বেশি। কিন্তু এটা আমাদের দেশে 100% সত্যি না হলেও যে আমরা স্লিম অবস্থায় আসলে ডায়াবেটিস ডেভেলপ করে ফেলি, এবং হাই সেন্ট্রাল ওবেসিটি, তার মানে হচ্ছে দ্য মিডল পোর্শন কামস আউট অফ দ্য মিডল এজ। তো আমি মনে করি এখানে যারা আছে সবারই একটু না একটু ভুঁড়ি আছে, এবং ডায়াবেটিক পেশেন্টদের মধ্যে 3 থেকে 4 গুণ বেশি হচ্ছে করোনারি আর্টারি হওয়ার চান্স, এবং ইনক্রিজ মোর্টালিটি ফ্রম কার্ডিওভাস্কুলার ডিজিজ, অ্যাসিমটোমেটিক আর সাবক্লিনিক্যাল করোনারি আর্টারি ডিজিজ এই সাউথ এশিয়ান পপুলেশনে অনেক অনেক বেশি। হায়ার প্রিভ্যালেন্স অফ সিকেডি, অলমোস্ট 40-fold increased risk of end-stage renal disease in our population. So our population একটা স্পেশাল পপুলেশন যাদেরকে টেইলর মেড ট্রিটমেন্ট দিতে হবে, যাদেরকে কনভিন্স করতে হবে ফর বেটার কন্ট্রোল। সো কার্ডিওভাস্কুলার হার্ট অ্যাটাক হওয়া ছাড়াও হার্ট ফেলিয়ার উইথ ইজেকশন ফ্র্যাকশন, উইথ প্রিজার্ভ ইজেকশন ফ্র্যাকশন সবই আসলে ডায়াবেটিসের জন্য হয়। সো ফান্ডামেন্টাল ফার্মাকোলজিক্যাল পিলার্স, আগে বলা হলো লাইফস্টাইল, ফ্যাট রিডাকশন, ফ্যাট ইনটেক রিডাকশন, সল্ট ইনটেক রিডাকশন, এগুলো বলা হলো। তো ফান্ডামেন্টাল ফার্মাকোলজিক্যাল এজেন্টস যদি আমরা বলি, আমি মনে করি যে 20 মিনিটস আছে, মনে হচ্ছিল যে প্রফেসর মহসিন এটা 15 মিনিট করে সেট করা আছে, ইয়েটা ঘড়ির কাঁটাটা, আমি জানি না, আই নিড 20 মিনিটস। এলডিএলসি লোয়ারিং, স্ট্যাটিন, ইজেটামাইড, PCSK9 ইনহিবিটার্স, এগুলো পিলার্স। 4টা পিলার যদি বলি, ব্লাড প্রেশার লোয়ারিং উইথ AC ইনহিবিটার অর ARNI, এটা একটা পিলার অফ CB প্রোটেকশন। ট্রাইগ্লিসারাইড লোয়ারিং উইথ ইকোসাপ অ্যান্টাইক অ্যাসিড, যেটা আমাদের শাফি মজুমদার স্যার বারবার বলেছেন, এবং উনি ট্রাই করছেন, কার্ডিওলজিস্টরা ট্রাই করছেন বাংলাদেশে এটা আনার জন্য, এখন পর্যন্ত নেই। আর আমাদের দিক থেকে GLP-1 রিসেপ্টর অ্যাগনিস্ট এবং SGLT2 inhibitors, they are established that they protect the patients from developing heart failure and heart attacks. সো এটা আমাদেরকে চিন্তা রাখতে হবে যে কীভাবে এই দুটো এজেন্ট আমাদের পেশেন্টদেরকে ট্যাগ করানো যায়। একটা কেস সিনারিও দেখায়, লাকি 13 days in CCU and post-CCU. Altaf Hossain, 51 years, a smoker, type 2 diabetes for the last 15 years, presented with sudden severe central chest pain, diagnosed as angiograph done, DVD, 100% LED and 92% LCX box, primary PCA done with LED to LED, and he is on insulin now. On discharge, what anti-diabetic agent should you prescribe to these patients? তার মানে হচ্ছে পেশেন্ট হচ্ছে সে হাইলি, তার মানে একবার হার্ট অ্যাটাক হচ্ছে আবারও হার্ট অ্যাটাক হওয়ার সম্ভাবনা রয়েছে, সুতরাং কী ধরনের ড্রাগটাকে দিলে তার হার্ট ফেইলিয়ার হওয়া থেকে এবং তার সেকেন্ড হার্ট অ্যাটাক হওয়া থেকে আমরা তাদেরকে প্রোটেকশন দিতে পারবো। পেশেন্টের GFR হচ্ছে 40 এবং HbA1c হচ্ছে 13.5। সো তার জন্য ডিসচার্জে কী কী মেডিকেশন আমরা দিব, তাহলে আমরা দেখি অ্যান্টি ডায়াবেটিক ড্রাগস উইথ প্রুভেন কার্ডিওভাস্কুলার বেনিফিটস। আপনারা, এটা আমার কোয়েশ্চেন টু দ্য অডিয়েন্স, whether pioglitazone is a drug that has got proven cardiovascular outcome benefits. Do you agree or not? Yes or no? No. Okay. Perfect answer. Acarbose. Yes or no? Though there are studies like prevention of diabetes, it has got acarbose great role. So it's false. Yes, it doesn't have any good cardiovascular protective benefits. Metformin, whether it has got good cardiovascular protective. Metformin, yes or no? Yes. So, but the number of participants ARTR-DS is low, and many of our participants are confused whether metformin, a simple drug like metformin, can cause give this kind of benefit to the cardiovascular. It's a cheaper drug, older old-fashioned. But it's yes. Metformin is the oldest drug that can protect you from heart attack. It's true. And it has got also efficiency or established that it can protect you from developing cancer, even like breast cancer and colon cancer. It has been published in a very prestigious journal like Journal of American Medical Association that metformin can prevent cancer even. So SGLT2 inhibitor, true or false? True. Much louder, right? GLP-1 receptor agonist, whether true or false? True. Louder, yes. So So all-cause mortality is reduced by 32% with SGLT2 inhibitor, like CV mortality, relative risk reduction 38%, and it's been clearly shown that the primary endpoint, fast adjuvant CV death or hospitalization heart failure reduced, and 22% reduction in the cardiovascular death with this kind of medicine. That's why the guidelines has been changed. Actually, after this AMPERAC trial, all the guidelines of diabetes worldwide, you know, the IDF guideline, the European Diabetic Association guideline, European Society of Study of Diabetes, and American Association, everything is changed after this trials of AMPERAC and LEADER trial, and after metformin it has been introduced, or even the patient is not taking metformin, the first line therapy could be SGLT2 inhibitor or GLP receptor agonist, according to European Society of Cardiology. And in Asian population particularly, there are extra benefits, like overall study population 38% relative risk reduction, but in Asian population, Asian subgroup of population, seen 56% relative risk reduction in this cardiovascular outcome, CV death. So clinical evidence of empagliflozin or dapagliflozin almost shared the same outcome of cardiac failure. Clinical evidence of patients with chronic heart failure. There are evidence that left ventricular mass, epicardial fat, oxidative stress, metabolic efficiency, oxygen supply, and diuresis, intraglomerular pressure reduction, vascular resistance, everything has been improved and ultimately improves the cardiovascular outcome. There are a number of studies that have been published and under way that the studies shows from 2015 to 2021, and number of studies are upcoming with lot of participants that it reduces the cardiovascular outcome. And it's been continuous whether the patient has left ventricular ejection fraction, reduced ejection fraction, moderately reduced ejection fraction, with preserved ejection fraction. In every spectrum of patient, actually, this SGLT2 inhibitor helps to hospitalization rate, lower the hospitalization rate. So it's a great drug, undoubtedly. The initiation in stabilized acute heart failure and the early outcome. So after the discharge, during the discharge, when the patient is stabilized after a heart attack or something like that, or heart failure, it has been shown that in placebo, 4.2%, 8.3% patient in actually all-cause mortality is reduced. All-cause mortality is reduced, and 10.6% and 14.6% that heart failure event reduction is possible with this drug. And optimization of the place in heart failure therapy, it has been shown that beta blocker, SGLT2 inhibitor, AC inhibitor, and MRA is associated with this good outcome in heart failure. And in European Society of Cardiology website, you can find that in 2021 that dapagliflozin and empagliflozin are recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. It's a class 1 and A recommendation. And you can find in ADA, American Diabetic Association guideline in 2022 that SGLT2 inhibitor, there are 3 classes of benefit, like a reduction of the ASCVD, reduction in heart failure, and progression of the coronary artery disease. In every spectrum, actually, SGLT2 inhibitor helps. And you can see that metformin helps to potential benefit of ASCVD reduction, and heart failure and progression of the DKD, it's neutral, but in case of ASCVD, it's beneficial, potential beneficial. So GLP-1 receptor agonist is another class of drug, GLP-1 receptor agonist. It has got also beneficial effects. It improves direct effect, improves endothelial function, nitric oxide increase, and vascular smooth muscle activation, decreased proliferation, vascular inflammation, and lipid accumulation. All these are reduced. HbA1c reduced, decreased weight, and decreased blood pressure ultimately leads to good cardiovascular outcome. There are a number of spectrum of these GLP-1 receptor agonists available in our country from once daily to once weekly. অনেক সময় পেশেন্টরা এসে জিজ্ঞেস করে, স্যার ফেসবুকে দেখলাম মাসে একটা করে দেওয়া যে ইঞ্জেকশন, আপনি আমাকে তো 4 বেলা করে দিচ্ছেন ইঞ্জেকশন, এইটা কি? আমি তো দেখলাম এরকম পাওয়া যায়। সো উই হ্যাভ গট দ্য অ্যান্সার নাও। আমরা মাসে একটা করে না দিতে পারলেও এখন পর্যন্ত নাই পৃথিবীতে কোথাও, কিন্তু সপ্তাহে একটা করে ইঞ্জেকশন দেওয়ার সুযোগ এসছে। এবং কমপ্লায়েন্স এনশিওর করা, আসলে আমরা এন্ডোক্রাইনোলজিস্টরা খুবই স্ট্রাগল করি যে 4 বার প্রিক করা একটা পেশেন্টকে, তার উপরে আবার 4 বার করে সুগার চেক করা, যারা খুব ফ্ল্যাকচুয়েট করে, খুব ডিফিকাল্ট। সেজন্য এই ওয়ান্স উইকলি যে GLP-1 রিসেপ্টর অ্যাগনিস্ট সেমাগ্লুটাইড, ডুলাগ্লুটাইড চলে এসছে, সো আমাদের জন্য ইজি হয়েছে জিনিসগুলো ইনস্টিটিউট করা। সো এগুলোরও বিভিন্ন রকম ট্রায়াল আছে। লিডার ট্রায়ালের কারণে, এবং আমরা বলছিলাম যে এম্পারের ট্রায়ালের কারণে আসলে সমস্ত গাইডলাইন চেঞ্জ হয়েছে। এটাই সে লিডার ট্রায়াল, যেখানে লিরাগ্লুটাইডের বেনিফিট দেখানো হয়েছে কার্ডিওভাস্কুলার আউটকামে, এবং 13% significant reduction of the 3-point MSE, and there are other CV, death, and non-fatal MI benefits. And non-fatal MI 11% reduction, non-fatal MI stroke 12% reduction, CV death 22% reduction, and primary outcome CV death, non-fatal MI and non-fatal stroke 13% reduction versus placebo has been shown. HbA1c, body weight, systolic blood pressure, everything is reduced, and leader trial shows all-cause mortality by 15%. And composite renal outcome is 22%, is good. So once weekly semaglutide shown by SUSTAIN 6 trial, and it has been shown that 26% reduction in the MSCE, and there are other benefits you can see in the chart, and the time is closer, and you can see that a lot of benefits from these once weekly injections. So 30% risk reduction in first concerned MSC time. We can purchase time by this molecule. 46% risk reduction in the first confirmed MSC in comparison to placebo. And microvascular outcomes also improves, like nephropathy. You can lower the microalbumin level by prescribing this kind of GLP-1 receptor molecules working given by once weekly. So but there are certain risks also, like increase the progression of retinopathy, but it's not for everyone. But the patients who are having retinopathy currently, advanced level of retinopathy, we should be careful about prescribing this kind of molecules, because if patient has advanced level of retinopathy, then prescribing this molecule can lead to bleeding in the inside eye. So a case, believe it or not, can you assume, can you guess what is the weight of this patient? Can you guess? 100 kg, 150 kg, 200 kg, any more, 230. Is it an auction, sounds like? So Mr. Alauddin is a 250 kg man, the highest man I have seen as of my patients. So it's he was 167 centimeter, BMI was 88 kg per meter square, type 2 diabetes, fasting 12 and after meal 18, HbA1c 8.5%. কিভাবে বাঁচাবেন এই পেশেন্টকে? বিদেশে হলে বলতো যে ওকে গো ফর ব্যারিয়াট্রিক সার্জারি, বাট উই ডোন্ট হ্যাভ দ্যাট স্কোপ ব্যারিয়াট্রিক সার্জারি। আমাদের দেশে 1-2 জন ব্যারিয়াট্রিক সার্জন আছে, যদিও আমি প্রতিদিন ব্যারিয়াট্রিক সার্জারির জন্য পেশেন্টদেরকে রেফার করে, আমি জানি তারা করবে না ব্যারিয়াট্রিক সার্জারি, বাট তাদেরকে টিউন করার জন্য যে আমাদের দরকার ব্যারিয়াট্রিক সার্জন, আমি শুধু রেফার করতে থাকি, সো দ্যাট তারা সার্জনরা একটু ট্রেনিং নিয়ে আসুক, আমাদের পেশেন্টদেরকে হেল্প করুক। সো আমরা পারি না ব্যারিয়াট্রিক সার্জারি করতে, তাহলে কী করতে পারি? সো দ্য কোয়েশ্চেন টু দ্য অডিয়েন্স, ফলোয়িং আর দ্য অ্যান্টি ওবেসিটি ড্রাগস, liraglutide, true or false? What is the pituitary condition? Yeah, pituitary is absolutely fine of this patient. Nothing in the pituitary gland. We have evaluated whether the patient is suffering from Cushing syndrome or not, Cushing disease or nothing is there. Thank you very much, sir, for asking the question. Following are the anti-obesity drug, liraglutide, true or false? There are 5 to 6 anti-obesity drugs approved by FDA. So anti-obesity drugs, liraglutide, true or false? Yes, this is FDA approved anti-obesity drug that can be prescribed even in non-diabetic patients. It's a anti-diabetic drug though. It can be prescribed in non-diabetic patients, lowering the weight. Metformin, weight reduction drug. Mixed answer is there. So mixed answer is there. So it's a false answer, because it's not an FDA approved drug for weight reduction. Most of the cases, it's a weight neutral drug. But in few cases, due to appetite loss, actually it reduces weight, but it's not a weight reduction drug approved by FDA. Orlistat, yes or no? True or false? True. Great. Naltrexone bupropion combination. True. True. Yes. Acarbose. True or false? False. Great. But we can see in the YouTube how to reduce your weight, how to reduce your blood pressure, how to reduce your cholesterol, how to reduce your blood glucose level. Feladin, diabetes, pressure, cholesterol এর সমস্ত ওষুধ আমি একটু সময় চাই কারণ এখানে 15 মিনিট সেট করা আছে. It was 20 minutes time allowed for me. I need 5 minutes more. So বলা হচ্ছে ইউটিউবে যে ফেলাদিন সব ওষুধ. আপনি মাখন খান, তেল খান, ঘি খান, মাংস খান এবং সালাদ খান, তাহলে সব ভালো হয়ে যাবে. এবং অনেক পেশেন্ট সমস্ত ওষুধ ফেলে দিয়ে খুব খারাপ অবস্থায় হাসপাতালে ভর্তি হচ্ছে, যাদের অ্যাকিউট প্যানক্রিয়াটাইটিস হচ্ছে. ইভেন ডাক্তার যারা এই ধরনের ডায়েট করেছে, আমার অনেক পেশেন্ট আছে হু আর ডক্টর, দে অ্যাকিউট প্যানক্রিয়াটাইটিস নিয়ে ভর্তি হয়েছে, অ্যাকিউট রেনাল ইম্পেয়ারমেন্ট নিয়ে ভর্তি হয়েছে আমাদের হাসপাতালে. সো কেটো ডায়েটে কী আছে? স্ট্যান্ডার্ড কেটো ডায়েট আছে 10% কার্বোহাইড্রেট, স্ট্যান্ডার্ড KD. স্ট্যান্ডার্ড কেটো ডায়েটে হচ্ছে 10% কার্বোহাইড্রেটের কম খেতে হয়. সো আপনারা এখানে দেখতে পাচ্ছেন এই স্টাডি পাবলিশড হয়েছে ভেরি প্রেস্টিজিয়াস জার্নাল, নিউ ইংল্যান্ড জার্নাল অফ মেডিসিন. এখানে দেখাচ্ছে যে যারা 50% রাউন্ড কার্বোহাইড্রেট খাবে তারা সেফ, কিন্তু যারা 40% কম কার্বোহাইড্রেট খাবে তাদের মোর্টালিটি বাড়তে থাকে. আবার যারা 70% বেশি কার্বোহাইড্রেট খাবে তাদের বাড়তে থাকে. তার মানে দেখেন, যারা 70% বেশি কার্বোহাইড্রেট খাবে অথবা যারা 40% কম কার্বোহাইড্রেট খাবে তাদের কিন্তু বাড়তে থাকে. আমাদের দেশে স্টাডি আছে রুরাল বাংলাদেশে 85% হচ্ছে আমাদের কার্বোহাইড্রেট কনজাম্পশনের রেট. তাহলে আমাদের আগে স্পিকার বলে গেছেন যে আমাদের কার্বোহাইড্রেট কনজাম্পশন কমানোর দরকার. আসলেই আমরা অনেক বেশি কার্বোহাইড্রেট খাই, ভাত দিয়ে আলুর ভর্তা খাই, ঠিক কিনা? মজা করে আলু ভর্তা দিয়ে ভাত খাই. সো এইগুলো আমাদের কমাতে হবে, কিন্তু কেটো ডায়েট করা যাবে না. ডেঞ্জারাস ডায়েট, ওয়ার্স্ট ফর্ম অফ ডায়েট ইন দ্য ওয়ার্ল্ড. আমরা কার্ডিওলজিস্ট, আপনারা জানেন যে ইউরোপিয়ান সোসাইটি অফ কার্ডিওলজি সার্চ করলে আপনারা দেখবেন এই স্টাডি 25,000 পপুলেশন এই স্টাডিটা করা হয়েছে ওভার 11 ইয়ার্স পিরিয়ডে এই স্টাডিটা করা হয়েছে. এখানে দেখা যাচ্ছে ইনক্রিজ ডেথ বাই কেটো ডায়েট. করোনারি আর্টারি ডিজিজের মাধ্যমে 51% ডেথ বেড়েছে এই কেটো ডায়েট করার কারণে. সেরিব্রাল ভাস্কুলার বেড়েছে 50% ডেথ ডিউ টু সেরিব্রাল ভাস্কুলার, এবং ক্যান্সারের কারণে ডেথ বেড়েছে 35% only due to keto diet. So are you interested to do keto diet and reduce your body weight? Who are interested? Anyone? No. আমি মনে করি কেউ মানে আয়ুকে স্যাক্রিফাইস করে কেউ তার ওজন কমাতে চাইবে না. এই তথ্যগুলো আমাদের অনেকের কাছে নেই, এবং আমরা অনেক ডাক্তার এবং ডাক্তারের আত্মীয় স্বজন এই কেটো ডায়েট করছি. ভেরি মাচ আনফর্চুনেট. সো এটা করার আগে একটু পড়াশোনা করে তারপর করা উচিত কেটো ডায়েট. আমরা অনেককে এই মডার্ন স্টাডিগুলোর কারণে আমরা অনেককে ভিলেন বানিয়ে দিচ্ছি. যেমন insulin, the greatest molecule of ever, of all times, the strongest anti-diabetic agent. তাদেরকে আমরা কি করেছি? আমরা ভিলেন বানিয়ে দিয়েছি. এবং দেখেন ডায়াবেটিসে অ্যাথেরোজেনিক ডিসলিপিডেমিয়া, আমার আরও সময় দরকার কারণ এখানে 15 মিনিট সেট করা আছে. কাইন্ডলি শেষ, আমার 2টা স্লাইড আছে, প্লিজ. টাইম ইজ আপ. 2টো স্লাইড আছে, হ্যাঁ. থ্যাংক ইউ ভেরি মাচ অর্গানাইজার্স. সো ডায়াবেটিসে কী হয়? অ্যাথেরোজেনিক ডিসলিপিডেমিয়া হয়, এবং ইনসুলিন কী করে? বেনিফিশিয়াল ইফেক্ট অন লিপিড. হাইপার কোয়াগুলেবল স্টেট হয় ডায়াবেটিসে. আর ইনসুলিন কী করে? অ্যান্টিপ্লেটলেট অ্যাক্টিভিটি অ্যান্ড সাপ্রেশন অফ দ্য PAI. প্রো ইনফ্লামেটরি স্টেট ডায়াবেটিস, আর অ্যান্টি ইনফ্লামেটরি হচ্ছে ইনসুলিন. এন্ডোথেলিয়াল ডিসফাংশন করে ডায়াবেটিস, এবং ইমপ্রুভ এন্ডোথেলিয়াল ফাংশন বাই ইনসুলিন. লাইপোটক্সিসিটি করে, এবং ইনসুলিন রিভার্স করে লাইপোটক্সিসিটি, এবং গ্লুকোটক্সিসিটি করে, ইনসুলিন রিভার্স করে গ্লুকোসিসের লস অফ বেনিফিট. কিন্তু আমরা ইনসুলিনকে ভিলেন বানিয়ে দিচ্ছি, এটা আসলে ঠিক না. ইনসুলিনের এন্ডোথেলিয়াল মেডিয়েটেড ভ্যাসোডাইলেটেশন রিমার্কেবলি এটা ইমপ্রুভ করে ইনসুলিনের মাধ্যমে. এটা আপনারা দেখতে পাবেন এই স্টাডিটাতে. এটা নতুন স্টাডি হচ্ছে না, কারণ সবাই এক্সপেন্সিভ মেডিকেশন, ফার্মাসিউটিক্যাল কোম্পানি তারা সেল করতে চাচ্ছে এক্সপেন্সিভ মেডিকেশন, ইনসুলিনকে ডাউনগ্রেড করছে. কিন্তু ইনসুলিন ইজ এ গ্রেট এজেন্টস অফ অল টাইমস. এখানে দেখতে পাবেন যে আমাদের শাফি মজুমদার একটু আগে দেখিয়ে গেলেন যে সিআরপি ইনফ্লামেটরি, আপনার কার্ডিওলজি সবাই অ্যাগ্রি করেন যে এই যে নন ক্লাসিক অথবা যেটাকে বলি আমরা রেসিজুয়াল রিস্ক, সিআরপি বাড়ার কারণে কার্ডিওভাস্কুলার ডেথ বাড়ছে. এই ইনসুলিন সিআরপিকে 22% কমায়. সো কেন আমরা এটাকে বেনিফিশিয়াল ফর কার্ডিওভাস্কুলার ডিজিজ আমরা কেন বলবো না? আমরা কেন ভিলেন বানাচ্ছি? এটা ঠিক না. আর আরেকটা জিনিস হচ্ছে যে আমরা সুগার কমাতে 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 অনেক বেশি কমাতে চাই, সার্জারি করে না যদি খালি পেটে 5, ভরা পেটে 6 এর নিচে না আসে। এটা মনে হয় যে উনি সার্জারিটা অ্যাভয়েড করতে চাচ্ছে, সেজন্য বলতেছে যে খালি পেটে 5, ভরা পেটে 6 আনতে। এটা আসলে ঠিক না। সো এখানে দেখেন অ্যাকর্ড স্টাডি দেখাচ্ছে যদি আমরা সিরিয়াসলি লোয়ার করতে চাই আমরা সুগার, তাহলে কিন্তু আমাদের কার্ডিওভাস্কুলার ডেথ আর অনেক বেড়ে যায়। সুতরাং এই স্টাডি, অ্যাকর্ড স্টাডি বলছে যে এক্সট্রিম লোয়ারিং অফ দ্য ব্লাড গ্লুকোজ ইজ ভেরি ব্যাড ফর হার্ট অ্যাটাক। সো in seeking, William Osler বলে গেছে, the seeking absolute truth to aim to the unattributable and must be content with broken portion. আমরা আসলে লিটারেচার দেখছি, আমরা স্টাডিজগুলো দেখছি, এটা আসলে ব্রোকেন পোর্শন। আমাদের অ্যাজ এ হোল অনেক কিছু সামনে পেছনে পড়া উচিত যে স্টাডিগুলো বোঝার জন্য আমাদের যে আসলে আমরা ফলস দিকে ধাবিত হচ্ছি কিনা। সো থ্যাংক ইউ ভেরি মাচ অ্যান্ড আই এম রিয়েলি গ্রেটফুল টু Professor Mohsin and Professor Wadud Chaudhuri sir who have invited me to this August gathering. Really grateful and honored. Thank you very much, sir.
Thank you, sir. Thank you, and congratulations to all the speakers for their brilliant presentation. Now the floor is open for discussion. And I also like to invite comments from our chairpersons and panelists.